We're going to let you choose. So there are only 6 prizes. Sorry, because the free night at Campbell's became an auction item. There is free attendance registration for next year's fall conference, $400+ value. Free registration at the spring regulatory conference, also $400+ value. That's at the Heathman Lodge in Vancouver. Let me see, there are 3 mystery items in here. It's a hint. It might be free lunch, and I don't mean a sack lunch. And then you don't even have to speak, but you can get Chucker cherries and a Seattle Chocolates candy bar without even speaking at the conference. That's what our speakers got. All right, take it away. You get your choice. Take it, and Tosca, our volunteer, is going to choose the winners. Catherine Patnode, ARNP. Oh, we should decide, must be present to win? Am I, because they might, no, okay. But how will we know what, is someone else from KVH here who can choose? You will choose. What would Catherine choose? Free lunch or, ooh, yes, or cherries and chocolate. That's also free lunch, right? There you go. All right, thank you very much. Okay. And thank you. Dawn, is it Meicher? CCHD, what is that? Oh, there we go. What will it be? Come on down.
I want to come for the husband.
Oh, there you go. Treats for the husband. How nice. Okay. The free registrations aren't like selling like hotcakes. Is it because your employer will pay for it? I hope so. All right. Josh Williams. Josh. Olympic Medical. Anybody work with Josh? Okay, so sorry. I'm cutthroat. I don't know what Josh would want, so. All right, Mariah Condiff, Heart Links. Yes!
When? Okay, so what are these?
Free registration to the fall or spring conference.
Okay.
$400+ value, but if your employer pays for it, then maybe you want free lunch. I'm just saying.
I don't know. Okay, where's the spring conference?
It's at the Heathman Lodge in Vancouver. You know, wouldn't it be good if I could remember? I don't remember. If you don't get it, we'll trade. How's that?
That's the one I wanted, so.
Okay, open it and tell me. In the meantime, is that the spring? All right, you got this. I must have put green on it for spring. I don't know. All right, and Anna Engel, Pullman Regional, an FOP, friend of Pat, right? Fall conference registration or mystery free lunch. There we go. You get to come back to Chelan. All right. Yes. Yeah. Okay. All right. We have 2 free lunches left. Brianna Collier, Walla Walla Hospice. Woohoo! Oh, you're Josh? Then you get the last one. There you go. Thank you. There's something inside. Thank you, everybody, for visiting our exhibitors. They really appreciate it. Thank you, Tosca. And if you want to go see if you won an auction item, you can go check it out. They are taking payments now, or you can hang out here until the session begins at 1. I think it begins at... Oh, yes, yes. Oh, do you have the who won it?
No, I thought that was you deciding.
No, we can put it back in, yes. Is that from Bree? Also, okay, oh, hey, there's one more. From one of our exhibitors. And I kind of commingled the ones who already won, so I'll try to not pick one who already won. How's that? I don't know, it's a mystery too. That person already won something. Oh my gosh, that person already won something. Sherry Osborne, Elite Home Health and Hospice. Is Sherry here? Anybody else from Elite? Oh, if you leave early, you lose out. What can I say? All righty. Stephanie Orth from kvhealth.net. Stephanie? Or someone, friend of Stephanie?
I know somebody.
You know? I don't know if we're going to count that. Everybody else is like, no, draw again. Michelle Pendergrass from Kaiser. Hey, you are the winner. And this is the nicest looking and the heaviest. Oh my goodness. Tell us what it is. Is it the composted pig? Sorry.
It's way too heavy for that. It's a big heart.
It's a big heart rock and a shirt. I'd rather be return me. Yes. Well, I don't, I'm not your boss, but sure, wear it to work.
If you're able to take a seat, we're about ready to get started. And hopefully you're in the right room. This is palliative care across cultures, impact of spiritual practices and spiritual beliefs on end-of-life decision-making and care. I'm Annie Anderson, and I'm a board member on the WSHPCO board along with Marie Eaton. And I'm going to read you some impressive bios from our speakers today. Dr. Marie Eaton is the community champion for the Palliative Care Institute at Western Washington University. She was the founding director of PCI, which partners with other community agencies and volunteers to transform palliative care in Whatcom County and support our human responses to living and dying. Dr. Eaton is also chair of the Northwest Life Passages Coalition, which builds collaborative networks between agencies that provide care for those facing serious or terminal illness in our region. And as I said, a board member of WSHPCO. During her 40 years at Western Washington University, she served in a number of other faculty, leadership, and administrative roles. As a faculty member at Fairhaven College, she taught courses on death and dying, which provided the grounding for her current work at the Palliative Care Institute. And then also presenting is Dr. Devyani Chandran, who is an assistant professor in the Human Services Program in the Department of Health and Community Services at Western, and the director of the Palliative Care Institute there. She received her PhD in social welfare from the University of Kansas. Her doctoral dissertation explored the experiences of older adults living with HIV/AIDS. She currently teaches courses on aging and health, interpersonal and small group systems, and diversity and social justice dynamics. Dr. Chandran's research focuses on community-based approaches to chronic illness, aging, end-of-life, and palliative care. Her research findings have been published in Social Work and Healthcare, Journal of Palliative and End-of-Life Care, Social Work Education, and AIDS and Behavior. Wow, that's a lot. She currently teaches I think I already said some of that. I think that's probably, thank you. They repeated part of your information, which is impressive, but I won't read it twice.
So are we up? Yeah.
So I am thrilled to be up here with Devyani. Devyani and I have worked together now for 3 years, and it's been a joy to be in collaboration with her. And one of the odd little benefits of COVID is that the palliative care institute's reach widened because we had to move to Zoom. And so a lot of the community and provider education we're doing now is available to you wherever you are. You don't have to come to Bellingham to get it. So we would like you to, just for a moment, if you would just turn to someone else at your table and share a little bit about some of your own experiences when someone from another culture or another spiritual practice was one of your clients. And I want to bring back into the room the challenge that David gave us yesterday morning, because I think part of what Devyani and I want to talk with you about are those populations that when they come into your space, you think, whoa, I don't know how to manage this. So it might be of someone from a different race, a different culture. It might be, perhaps you are queer and you're working with a straight person, or you're the straight person trying to work with a family that has LGBTQ plus allegiances, and you don't quite know how to manage that. It may be that you are an evangelical Christian and your client is Jewish. It may be that you're working with someone from one of the native tribes in your region. So just for a moment, share an experience you've had where you felt that sort of, oh my God, how am I going to manage this one? Give you a minute. Did you get for being short?
I feel like every time I go to I shrink a little bit more.
Oh, I have shrunk 2 inches.
So when I came to the US, it was in India, the average family have an arrangement when you put out more than 7 like 5 feet is like just something to say. So my mom like, oh no, she's like, I'm American. I was born and she said 5 feet. And I came in here for my first doctor's appointment when they were like, and this is like all my life, right? And I was like, you know, and if I'm 5 feet, then she's 5'4", right? This is a doctor, isn't it? And then I have a cousin who's really tiny, and sure enough, she comes to visit us, and she's like, I'm 5 feet tall. You know, it's just all of us in India, we're all 5 feet tall.
That's funny. Okay, you may not all have had a chance to tell your story, but if you could bring your attention back to the front. I could hear there's some good stories there. So holding that story in mind, or those stories in mind, Devyani and I are going to describe for you some key learnings from a 6-part webinar series that we did, a year and a half ago? A year and a half ago, where we had 6 different sessions that explored the intersections between cultural identities and belief systems and the kind of care that, and the impact that that has on their care. We're going to showcase a few little studies and vignettes from the series, and at the end we'll give you the link to the series, because these videos are all available to you if you want to explore this a little more deeply. And I just truly believe that this series would help you meeting the challenge that David gave us yesterday. The one population, 2 problems, 3 solutions. And I think we're going to hopefully help you on that road into providing better access for all your folks.
Thank you, Marie. I was just telling Marie, when you're 4'10" like me, you're kind of banging around the mic a little bit. And so I think it's also important to kind of talk a little bit about how we came upon this particular series. And as Marie said, we did shift a lot of our face-to-face work to going online because of COVID. But another sort of motivation for us to do this was that we had worked on a project called the Touch of Grace project, which we presented out here before. And one of our findings from that particular project was the impact that culture had on people's experiences of pain. And as someone who's South Asian myself, I mean, it's something that's very intriguing to me, that, if you go and ask a patient on a scale of 1 to 5, what do you feel? My grandmother and perhaps someone else's grandmother may feel the same level of pain, but describe it very differently because of the way that we've been raised, or because of how we've been told to talk about pain. And who knows, maybe because of our own sort of physiological response to pain. It's really difficult to kind of quantify what is going on in a body and how that interacts with the mind. So this took us on a journey in just to kind of think a little bit about culture. Right, to think about culture and to think about the fact that death and dying, our experiences of palliative and end-of-life care, are not just things that are related to the body, but are related to our larger whole person experience. And so the framework that we've kind of tried to use over here is what we call the biopsychosocial cultural spiritual framework. And this is something what I think of a framework that keeps expanding, and it's interesting to me. If you were to go out there and actually look for this, you would find something stopping at biopsychosocial. So a lot of times when we think about health, there's the biology. We all know that social networks are important, right? And mental health is a big piece of our conversation when we think about how people experience life and health or illness and care, right? And then at one point of time, at least, I know within the social work literature, culture came into the conversation, right? That culture is important. It can sort of impact people's experiences. And then there's the spiritual aspect of it, right? And for some of us, the spiritual kind of intertwines with the cultural, but for a lot of us, it can be a deeply personal journey that may not actually be a part of our culture of origin, right? It may be something that we've come across later in our lives, or we've given up, or we find other ways of expressing it, but still definitely, a part of our conversation. So just some things to consider, and I know like Marie kind of brought up a few in her introduction, but I just think, this is, I feel like basic stuff in some ways, but age, and we are here, so age, yes, but race, sex as it is assigned at birth, ethnicity, disability status, sexual orientation, gender identity, education, geographic location. So are you rural versus, your experiences of care in a more urban setting? It can make a huge difference in how you experience care. And religion or spirituality as you and your community choose to express it. So as Marie said, just taking all of these things into consideration, we went out there trying to find speakers who could, within their own cultures, address a lot of these different practices. And we got a wide range, right? We got people who are medical providers, we've got community-based care providers, we have people who come from the tribes. It just kind of went across the spectrum, and there was an immense amount of richness and I think depth. But also what we came out with is that, at least to my mind, I wanted to go beyond the story. And I think a lot of times when we discuss culture, I know even in my own practice, I'm like, I get it, right? It's deeply meaningful, it impacts people's experiences, but then I'm always left with, and now what do I do with this information, right? How do I actually bring it into my own practice? And so for each of these people that we spoke with, we said, just leave us with a little bit of information about what can we go out there and tell people, not just about what exists within communities, but what do you do with that information? So I'm really hoping that you get a little bit out of some of the clips about what to do with that information and not just what exists out there, even though both of those things are deeply interconnected.
So the way this is going to work is we're going to play some clips, just short clips from the webinars that'll give you a little taste of what each webinar was about and the kind of concepts that we were dealing with. So the first webinar was called Cross-Cultural Palliative Care, Finding Alignment and Tools. And our speaker was Dr. Jody Waldron. Jody is at UW. He's a board-certified physician, and he teaches general internal medicine at the University of Washington. But he has a deep, deep interest in providing culturally sensitive care, particularly to the underserved and immigrant communities in Seattle. And he firmly believes that the practice of medicine depends heavily on collaboration and communication between the patient and the provider. So he drew on his own deep experiences living in and working in Africa for a while, and he has spent time coordinating a educational partnership between the University of Washington and the University of Nairobi. So he's got a lot of experience. So this is Dr. Waldron. Where's the little, right there.
On board with. That's usually what the people are looking for when they say that, goals of care. Thank you for the question. Okay, so what I consider tool one, own your own bias, okay? Before you go into an encounter with a group that might be unfamiliar or in a cross-cultural situation, own the bias that you're coming to the table with. We are all human beings. This is a part of the way we make decisions for ourselves. We form decisions based on patterns. Doesn't mean we're terrible people. It means we're human beings. And those biases are real, and they affect kind of how we make decisions. So this is a quote from a book from the late 60s, which I feel like still is very applicable to now, dealing with the sociology of death and disease. Basically, the American middle class, future-oriented, individualistic, bent on mastering nature, and concerned with doing. Kind of being active feels better than kind of being passive or receiving kind of what may happen. Okay, and I chose this Norman Rockwell painting to kind of simulate, all the generalizations that are kind of in this quote. And basically, these values that have been highlighted over time have been distilled into what has become the normative values of palliative care, okay? And I think you can see some of the trends that are there, okay? Patient autonomy, okay? Big, very important thing. The person has the right to decide for themselves what's most important, okay? That's coming from this tradition of individualism. Truth-telling. You've got to know your diagnosis. You've got to know the medical information. Your doctor has to tell you the truth. Even if it's terrible, bad news, they have to tell you the truth so that you can be empowered to make decisions. That's a part of this informed medical decision-making, mastering nature up in the description. Basically, we want to have so much control that even if we have a stroke and we can't speak for ourselves, we do advance directives so that we can still have control over the process, even after we've lost that ability. I think that speaks to how important these qualities are. I want to highlight the fact that these things are not universal, okay? These values are not universal, and many cultures approach things very differently. And these values are kind of are European American or Western derivative values, and they are the bedrock of what we think is the norm of palliative care. Okay, so I just want to raise a little bit of perspective that these fundamentals actually are pretty culturally specific, and to be a little bit cautious about them. Okay, and I'll go into a little bit more about what I mean about that. So this is a really helpful chart from an article cited below, that a derivative of several different studies. And as you can see up at the top are some of the qualities that I mentioned about kind of foundational palliative care, end-of-life values. So belief in the advance directive, does it make sense culturally to be able to put your wishes down on paper such that if you lose the ability to make a decision, that your family has guidance? Okay, patient autonomy. The patient should always decide what happens. The doctor maybe less so, family maybe less so. Informed decision-making. Basically, the patient has to be told everything so that they can make a decision. Truth-telling, even if it's bad, you have to tell the person. And then the dying process, whether this is something that folks want to have control of. Okay, they want to decide, oh, where do I want to be? What music I want to have playing? Who are the people I want at my bedside? I want my dog there. Is that something that control is an important part of, or is it acceptance that's more of an important part of that? So, these approaches are very different among cultures, and I will just highlight. So you can see European Americans down at the bottom. Okay. The things that line up with European American values tend to line up with the palliative care normative system, okay? Yes, we believe in advance directives. Yes, we believe that patient dependence is important. Patients should be fully informed to make decisions. Truth-telling, even if it's bad, is very important, and patients should have control over the dying process. That's felt to be the norm, but it's not the cultural norm. It doesn't apply to all of our people that we're serving, okay? And I'll highlight a few examples of where that can go astray. Okay, again, these are generalizations and not meant to speak to any specific family, but these are from studies cited below. So 72% of Korean families felt that a patient should not be making their own life support decisions. It's stressful to talk about life support. Why are we making a sick person talk about it? This should be a decision that a family would talk about as an alternative to the patient themselves. Okay, another example for Hispanic or Latino Americans, so 46% of Latino patients would want their doctor to make a decision. So basically, in some communities, it might be felt that the patient is not the most informed medical person on the scene, so why are they making the decision? Why don't we let the medical expert make the decision? Sometimes you'll come across this as a pattern in culture. The other group I also want to highlight specifically is that Native Americans, and I realize this is a large heterogeneous group, but I want to highlight, again, a generalization. If you follow the European American kind of trajectory up to our values that are kind of embedded in the system, you'll see that it's not uncommon that Native American populations fall outside of what we would what we've put in place as the systemic values that come into play when we're having a palliative care conversation. Okay, so it's just, I want to plant the seed that these things are relative rather than kind of bedrock humanity. These values are specific. Okay. So that's what I mean when I say Western bias. Okay, so owning your bias and recognizing that we're coming from a biased system is really important. Okay, just having that perspective. The other bias that I think is very important for us to be aware of is our bias as a healthcare provider or as someone who's thinking about advanced care planning or seeing medically ill patients. We do not represent the general population, okay? And to give you an example of this, a small survey of about 1,100 younger doctors, about 90% of them said that they would not want CPR in the setting of a terminal illness. So 90%, they may be informed by their own experience, et cetera, but basically, as opposed to the population coming into an ICU that have a DNR order, and I realize this doesn't cover everyone who would not want CPR, but only 10% of all comers coming into an ICU have a DNR order. So I would say that there is a discrepancy between medical professionals and what we tend to want and the general population and what they tend to want. So just be careful that your values don't get forced upon the community that you're serving. Okay. The other thing that I want to stress is, when I was a resident and I was interested in palliative care, I thought that palliative care was saying the hard thing in the nice way that got the family to do the right thing. And I think about that very differently now. I feel that palliative care is not advertising for how to advertise what the doctors want so that the patients believe it. It's actually how do we learn about the patients, learn about their values, incorporate the medical information so that we can make a plan that the patients and families appreciate. It's using the patient's values rather than the doctor's values. So I think that that's an important distinction, that it's not just saying the hard thing nice. And really, a palliative care win is not convincing someone to do what you want them to do. A palliative care win is finding alignment between you and your patient, or the medical team and the patient. I think it's also really important.
Is that the end? Yep. So Dr. Waldron there is challenging some of the assumptions that we have about what palliative care means and what hospice care means. And I think I was reminded listening to this of Dr. VandeKieft's advice yesterday that you always ask the patient. So leaning into the patient's narrative and to try to discover what it is that they need.
On board with. That's usually what people are looking for when they say that goals of care.
Yeah. So webinar number 2 was providing a culturally relevant palliative care system as a community. And our major coordinator there was Gurpreet Dillon, who's the director of Hospice Palliative Care and the Cancer Center at Peace Health St. John. Well, that's what he was when he did this. He now has a new position. But so Gurpreet used interviews from care providers in various cultural groups to explore some of the challenges in access and perspectives about palliative care in their communities. So using informants from those communities, from care providers from those communities to say, what do you see as the challenges? And so here's just a couple of little quotes from that webinar. So one of the community members said, it was a reminder for me that even if I've cared for somebody of the same ethnic or religious group in the past, my current patient may have different wishes for their end of life. Every patient has their own preference. I also really like the quote from Dr. Kalapudi that death comes for everyone at some point. When death comes for you, what can your healthcare team do to support you? So that's the invitation to get information from your client about how they could feel supported. And then a reminder not to make assumptions, to ask the patient and the family about the values and what's important to them.
Thank you, Marie. So the first 2 webinars that we did just kind of had like the one individual provider, like providing us with like some really relevant information. And what we ended up doing across all of these webinars was ask our participants, and we kind of range from about 50 in one webinar to going over 100 in some of them, just what they were learning from listening to this information. And there's really a wide spectrum of people who attend our sessions. And so we do have people who are medical providers and nurses, but we also have community-based caregivers. And sometimes we have family caregivers as well, right? So I think one of the things about being a community-based palliative care organization is the fact that we serve such a wide spectrum of people and that it's not siloed in any way. So our third webinar was actually a panel discussion, and I think this was the only panel discussion that we had. I think all the rest of them were more individual. And we had 3 panelists, Jenna Bowman, who is a member of the Tulalip Yakima tribe, Australia Hernandez Cosby, who was the promotora at a community-to-community development, and Geraldine Wrights, who's the hospital chaplain at Peace Health, St. Joseph Medical Center in Bellingham. And what we had them do was actually respond to a single case study of a patient who was at an end-of-life situation. And we asked them to reflect what that would look like from the perspectives of their own individual communities, right? So a lot of times, I mean, with my students, I do this, that if we strip away identifiers from a case study, who's the person that comes to mind? And very often the person that comes to mind is the person who's closest to our own ethnicity, right? Because those are the people we are most familiar with, or those are the people that we actually provide the maximum amount of service to, or even if we are not service providers, those are the people we've seen in our families, right? And it led to, I think, a very lively conversation where, it was not just about them being providers in their respective communities, but also being member providers, right? That they actually had membership in those communities, but they were also providing services within these communities. And at one point of time, I remember sharing my own story about, trying to talk to my grandmother, who's now 94, about end-of-life care. And half of us are in the United States, half of us are in India, and we thought, having a conversation about a will was a good idea. And she screamed at us saying, "So you want me dead and you're trying to kill me?" And that pretty much ended it there. And we haven't ever had that conversation with her ever again, because that's just, one, we don't want to distress her, but it's just culturally completely inappropriate. And half of us have made this journey to the West where we think, wow, this autonomy is fantastic. While she's lived there all her life, and she's like, what are you talking about? I'm 94, you're in charge, and you make the decision, and why would you even try putting that on me? And is this an appropriate time to try to take my money, right? And so it was just, I think, interesting, and in so many ways to actually have this conversation. The next webinar that we had, which was really, I think, addressing a really important but difficult conversation, right, which is racism in healthcare, right? I don't think we talk enough about racism. And Tracy Ning, who was the person who actually conducted the webinar, is a licensed master's in social work worker in a palliative care social worker, and she works at the Advanced Heart Disease Service in Brigham and Women's Hospital in Harvard. And so it was one of those, fortuitous things where we were able to actually get her, right? So Tracy was supposed to do this for us when she was actually Seattle-based, and then got married and moved to Boston, and then COVID happened, and we finally managed to get her to talk to us on this webinar. And so I'm going to show you a small clip of this, and I think it challenges us in so many ways to talk about racism, right? And I think that's core to a lot of work that's being done, and is a very critical conversation that needs to take place.
And I think that now, with everything that's happened with COVID and the protests with George Floyd, Breonna Taylor throughout the summer, it feels more obvious, but I felt like it was still important to really focus in on why it's so important to be discussing this topic for palliative care providers. And so there are, of course, ethical and professional reasons, and we just have moral obligations in general. It does affect the care that our patients receive, which I think is why a lot of people might find this an interesting thing to discuss, because palliative care providers across the board want to provide the best care that they can to their patients. And there is an impact on our providers and our teams. And as interdisciplinary teams, we work with a lot of different people. I know a large component of the work that we do as palliative care providers is also helping and supporting our staff, the other people that are taking care of patients. And so just to be aware that there is an impact on all the people we work with in addition to the patients. And then, of course, COVID-19 has really highlighted the disparities that exist in our healthcare, and it's created this moment where people are really wanting to do things. And so it's important that we are able to step up into that moment as well. So the U.S. Department of Health and Human Services, the Joint Commission, and the Institute of Medicine, they have made the achievement of health equity and elimination of racial and ethnic disparities in healthcare priorities. So they've started to recognize that this is a problem and it's something that we need to work on. Many of the disciplines that make up our teams, they have a shared code of ethics that promote compassion, respect, and human rights. And most of the professional associations that we're affiliated with also stress the need for social justice. And in 2018, the National Coalition for Hospice and Palliative Care put out clinical practice guidelines for quality of palliative care that calls for inclusion of historical trauma as part of the assessment that we do for our patients. And I think especially going back to the roots of racism, this is a part of it. Like, there has always been a history of trauma that people experience, and it can be intergenerational, and it carries forward into the experience that our patients have today and how they interact with the healthcare system. And they also recognize that social determinants of health impact the care that patients receive. And I think that now, with everything that's happened, with
the next one. All right. So, as I said, we do have like this entire thing online, and we will give you guys a link. So I'm just like putting out snapshots out there right now. But one of the things that, sort of Tracy, I think, addressed beyond like talking in depth about racism and how it manifested in her unit, particularly during COVID. So that felt like a lot of the socially correct spaces that were created to treat people kind of actually went away when there were high levels of stress. And so this is something, historically, I have seen, at least in my own reading of the work, happened when HIV/AIDS broke on the scene, right? I mean, in the 1980s. A population that was deeply stigmatized, who was behaviorally stigmatized, right? Because they technically had a disease that they were responsible for. And we kind of saw that happening again during COVID, where communities were, penalized again and again in terms of how they received care, because it was perceived that, in some ways they were not being able to socially isolate properly. Or they lived within these large intergenerational settings where isolation was not possible, right? Or lived in economic circumstances where that was not something that they could enforce, right? And it led to, I think, some really serious schisms within the healthcare systems, and for a lot of providers who were not just, on the receiving end as patients and who had family members. As we all know, COVID affected pretty much everyone, including everyone in this room. It was also about being that provider of color in that space and seeing that happen to your own community or other communities around you. And it was a deeply distressing experience, leading to a lot of questioning about how care was provided and how culture was understood, particularly when people were approaching the end of life, as vast numbers of people did during the pandemic in unprecedented numbers. And so, just in terms of like the feedback that we got from some of our participants, Tracy spoke a lot about culture change, which was more of an organizational strategy versus an individual strategy. And so if you look at Jody Waldron's webinar, Dr. Waldron, really sort of talks about the individual medical provider and what can he or she or they do in terms of like changing their practice. I think Tracy's work was more about what can organizations do to actually create an environment where it's possible for people to actually both work and receive care in an equitable manner. And we saw that reflected in the feedback that we got back from people who actually engaged with this webinar. And so they really appreciated Tracy's comments about fostering culture change. And then, they also sort of really appreciated the acknowledgement that racism is by no ways necessarily a one-way street. It can be back and forth. Providers can experience it because of their own identities as well and can grapple with sort of, the implications of that, right, and how they choose to provide care. So even I think about, my basic social work training, it's one of the things that they tell you, right, that clients are human beings and you cannot expect perfection. Things go wrong, people say things, and you still have to provide the optimum level of care. But then you bring sort of race into this particular mix, and then you have a whole different conversation going on about not just about providing care, but also provider integrity and self-protection, right? And so it was a very challenging and difficult conversation. We were really grateful that she was there to have it. Marie.
So webinar number 5, we turned the lens on the caregiver. And as many of you may know, in your communities it may be as well, that many of the in-home caregivers or CNAs come from cultures other than the dominant white American culture. And our speaker was Marinelle Kinsley, who is a research manager and coordinates community-based research for the Community Health and Social Innovation Hub at the University of the Fraser Valley in British Columbia. And she did her master's research on immigrant caregivers, particularly those from the Mexicana background, and examined the impact of their caregiving roles and the challenges of providing care across cultural identities, because many of these caregivers are working with people who do not share their own Mexicana background. And so how do we negotiate across these cultural identities in both the recipient of care and the caregiver themselves? And she examined the disconnect between the mainstream culture and the care needs of elders in communities, and how caregivers can be supported to express their cultural values and knowledge to the benefit of the patient. So here's a couple of the comments back from our participants about that webinar. Cultivating connectedness with staff to learn more about them as individuals, which may include cultural knowledge and values. Encouraging and promoting these is beneficial to all. So this came from someone who supervises caregivers in the home. The application of culturally sensitive practice applied in palliative care practice, providing person-centered care and allowing the values to precede medical judgment. And then we need to be able to reassure people that their values and their wishes will be honored and that their status will be safe. So we thank Marinelle for that.
Right. And so our last sort of webinar, which I ended up doing, was looking at immigrants and who are undocumented and thinking about challenges to healthcare access. And this was just something I think that was really personal to me. I am documented and have received, I think, some excellent medical care across my stay in the United States. So I came here in 2014. I was just regular preventative care. I've had a child in the United States, all of those things, right? But it's been interesting, I think, sort of being in conversation with other people whose documentation status has not been as secure as my own, both as someone who provides care or has had interactions with people where half the family is documented while the other half is not, right? And it just sort of raised these questions where I think I was trying really hard to find information, actually more for friends who said, what do we do if we have a family member who's undocumented, who needs care, right? And I was just kind of like trying to do patchwork, right? It was very difficult for me to actually find a cohesive place to go in there and say, okay, you're not exactly low income, but you're undocumented, but you have all of these other identities. And you also seem to have some sort of an idea about end-of-life care. What does that look like? And so the last webinar that I ended up doing was, thinking about immigrants who are undocumented and looking at sort of both barriers and possible solutions that actually vary state to state. So Washington State has a few sort of like programs that are actually available for undocumented immigrants in terms of accessing care. But that's not necessarily something that works nationally, right? And coming, I think, from a perspective, I think, regardless of our value, our ideas about immigration, documentation, and legality. Health is unfortunately or fortunately something that we have to take care of, because regardless of how you look or where you come from, if you fall sick, it's very likely other people will fall sick as well, right? So that's something that we keep central as a human rights perspective, I think. So I'm just going to play, I think, 2 clips. One, which looks at the barriers to healthcare, and then possible solutions to the care. You have that conversation when you may not actually access the care. And we assume that I think a lot of undocumented immigrants are ensconced in their families, and that's actually not true. A lot of people come in as individuals, or they may come in, as a group of workers. And so you don't have family members, right? So who takes care of you if you actually fall sick or, God forbid, come to the end of life? Language, definitely a concern. This is something that we've seen come up across this webinar series, that, there is the primacy of the English language in most spaces. Documentation takes place in the English language. Advanced care directives are most easily available to you in the English language. And that's not a big surprise. I mean, it is the primary language in this country, but if you're undocumented, or for the matter of fact, belong to a culture where the English language is not your primary language, it really leads to a lack of trust in what a doctor is saying, and a complete lack of power. And this is something that I've seen even in my own experience. And even if you know the English language, I mean, there may be like vast variation in accents and how language is communicated to you. It's not easy to understand what is going on within the healthcare system and documentation. Even if you are familiar with the English language, it becomes infinitely harder if you're someone for whom this is not a primary language. And so we find that, there's a low education level, probably a limited social system, and a distrust of systems in general, just because of fear of deportation. People who are undocumented are very much aware that they are not wanted in. You have that conversation. The last one. What we found is this regular sort of engagement in public health advocacy, and so a lot of the efforts that are taking place take place much more at the local and community and maybe even the regional council levels, where individuals are recognizing that, when we talk about dignity in death, dignity at end of life, it has to include all individuals, regardless of immigration and citizenship status. And so conversations about how that may be done are like really important. There needs to be a recognition that, this is an issue that is not just like limited to the United States. I mean, this is something that we find across the world, Canada included, where there needs to be a recognition that, sometimes people are undocumented and they do find themselves in these situations, and there needs to be agreements in place where people can reunify with their families regardless of their immigration status. Within the United States, there's been a considerable amount of conversation about providing access to emergency Medicaid programs. And right now, and so a patient would not access the regular Medicaid program, but would have access to certain emergency provisions. So what we found, so as we kind of came, I think, to the end of this particular webinar series, I think we started out with thinking about the whole person, right? So when I sort of said the framework was bio, psychosocial, cultural, spiritual, looking at every aspect that a person was engaged with, I think our solutions actually kind of come from, where are we working as a system, right? So where are we as individuals in our professional careers in terms of how we actually advocate for someone who comes from a different culture? What do we see actually happening within families and communities around us? So I, now have a school-age child, and it's very interesting to see what happens within schools about intergenerational conversations, about culture and where those conversations go. I think communities is, our bread and butter. It's kind of where we, as an institute, operate, right? But recognizing that our understanding of community is a continually expanding understanding, right? And more than anything else, I think a lot of times the work of like advocacy at the local, national level, and thinking about where we stand globally, right? And I think more than anything else, when we look at conferences of this kind, our work may be in a specific location, but our impact is actually global, right? I mean, it's really sort of far-reaching and expanding. And in a similar sort of way, global trends are not things that we can escape in any way in the societies that we live in. I think COVID was a great example of how that actually plays out. So I'm going to let Marie just conclude our presentation for today.
So I want to provide this link, and I want to tell you a little bit about this CEDAR project. So Western Washington University, where the Institute is housed, has a digital repository, and the Palliative Care Institute has a site in that depository. All the videotapes from this series and from all the other conferences and webinars we've done are available there, and they're available to you for free. Some of them may be useful training videos or conversation starters for your staff, where you might watch a video together and then have a conversation about how does this play out then in our own institution. So this particular series, this is the link for the 6-part series on cultural impacts. But there's some on psilocybin, there's some on, the one that's coming up is on medical aid in dying. That will be on the CEDAR site as soon as the webinar is over. So we just want to make sure that you know that this resource is open to you. So there's a little bit of time for some questions or comments, or if anyone wants to come to the mic and share a story or a reflection about what Devyani and I had talked about today. Okay, I'm going to remind you of David's challenge then. 1 population, 2 problems, 3 solutions. So, and hopefully these webinars will give you some possible ideas about solutions. So thank you so much.
Hope I'm not on, am I? Or am I? There we go. I know, it's that time of day, but this is going to be great, got to tell you. So I think I'm Pat Justice, and I think I'm a board member, but that's to be concluded. I don't know how the vote came out, but that's why I'm up here doing this introduction. And I asked to do this one because these are my people. You've heard Gregg VandeKieft, Dr. Gregg VandeKieft, introduced a couple times. So we're going to say that he is the medical director for the Washington Rural Palliative Care Initiative, and he loves working with this team and has a long history in palliative care in many settings. And then next, this calls for glasses. Goldberg, who's sitting by Gregg there, is an LICSW with a PhD or a doctorate in social work. She has over 15 years of palliative care experience, and she was a recipient of the Swippen Clinical Social Work Award in 2019, and she is one of our telehealth panelists, if you weren't in the session where we talked about that. Moody is an RN and I'm not going to do all the letters, but you've got considerable there. She's been a registered nurse for 15 years. She has a diverse clinical background, including critical care, cardiac interventions, outpatient dialysis, and for the last 2 years, palliative care. She is the inpatient palliative care nurse for the local and telehealth interdisciplinary team for 2 critical access hospitals in Stevens County, Washington. Amber has a passion for rural health care and ensuring that the community she lives in has equal access to specialty palliative care consultation. In her free time, she enjoys spending time outdoors with her children and animals on their farm. Eve Kelly Corcoran is a chaplain. I'm not going to do all your letters, too. She likes yellow. Oh, I know that. She's worked as an educator for 14 years and in the healthcare field for 23 years. As a chaplain, ethics coordinator, palliative care director, retreat facilitator, and artist, her creativity and passion for palliative care and hospice work brings meaning and purpose to her world. Caring for those who are vulnerable and ailing, educating executives, providers, and healthcare staff to bring harmony and excellence to programs of care is her main focus. Lifelong learning and an appreciation for people and their individual gifts is an avenue of invitation for those seeking to learn, grow, and deepen their connections with their teams. Kelly and her husband live on 30 acres in rural Stevens County. She loves to garden, walk with her 4 dogs, read, and paint in her spare time. And with that, I'll turn it over to the panel.
So before we get started, I'm going to ask Chaplain Gretchen to go to the mic and tell you how we got the title of this presentation.
I believe this was taken verbatim from a text sent to the team when we had a workstation on wheels in the room, ready to go into a room, but heard from the family that they were delayed because dairy cows' schedule complicate things.
And so here we are. Thanks, Gretchen, for being called off the cuff. I'm going to skip this one because we've all been introduced so many times, and Gregg, you probably could, it didn't change. Oh, do we have to change up there? Dang.
That's true, that's your laptop.
That's my laptop. Can we?
Do you need a slide changer? Or are you all right?
We're good.
We're good. Anyhow.
I'll just stay up here.
And we're sure Gregg, you could all introduce Gregg by now, so we'll move on.
80 suggested I put a brown paper bag over my head for this session.
So go for it, Gregg.
Okay, so we have no financial or other conflicts of interest to disclose. Learning objectives today, we'd like to talk a little bit about how to design a palliative care needs assessment for rural hospitals. And again, the person in the room who you really want to tap into if you're trying to do that is Pat Justice. Describe program development and clinical delivery of palliative care consults versus a blended in-person and virtual palliative care interdisciplinary team. What we're going to unpack is many times it's looked at as either or. Do you do virtual encounters or in-person encounters? And what we're going to describe is having people on the ground who are palliative care experts with the other members of the team beaming in virtually. And then thirdly, describe the Washington Department of Health's Rural Palliative Care Initiative. We're not going to replicate the panel that we had yesterday, but we will talk about how that initiative was instrumental in this particular project getting up and running. Is this you, Kelly?
I think so.
Okay.
You're going to turn the page? Oh, you did turn the page.
Keep up.
It's been a long 2 days, hasn't it? Go ahead, Kelly.
So the first thing you need to do is know your team, not just Blanche, Joe, Bob, Sally, but what drives them. What strengths do they bring to the team? What are their challenges? In a perfect world, what do they see the palliative care program as? What might be some solutions to tough situations they were in the past? So have those conversations, those one-to-one conversations, because it does 2 things. It gives you an invaluable amount of information as to what might be a good fit for your team that you are developing, but it also begins that layer of trust that your team needs to have with you as the leader.
So you want to talk a little bit about the community that we're working in?
So our community in Stevens County is the entire county is smaller than probably the 4 blocks around Providence Medical Center in Seattle, where I was born. It's in 3 years, we will have over 50% of our population age 65 or older. We're at about 38% right now. We're very rural, and when it snows, all of a sudden, rural is exponential, right? So transportation is a huge access piece. The other part, and I kind of spoke to it, I just mentioned it yesterday, is there's a bit of a distrust for the medical world because these people are independent and they could do it on their own. They have for 87 years, so why should they turn over anything to some doctor they don't even know and who hasn't lived in Stevens County for, 18 months. So that's kind of what we're dealing with.
So that Stevens County is a snapshot of rural America. And so 15 to 20% of our country, our nation, lives in rural communities. And that definition sort of is fluid in terms of how rural is defined in terms of benefits, services, distances from large cities, all sorts of things. Given that, though, what they share in common is geographic isolation from large urban centers. In general, when we look at socioeconomics in rural communities, it's less than the larger urban centers. As Kelly mentioned, older age, limited job opportunities. Colville had a lot of lumber as part of its history of a community, and lumber has really shut down in eastern Washington. As a result of lower employment, there's lower insurance rates, lower insurance enrollment because there's not a lot of employer or offered insurance benefits. And then what is a nationwide problem that we struggle with is that less than 8% of our medical workforce elects to spend their time in rural communities. And then when you add on to that, limited specialty care.
And the next slide.
Yeah.
And I believe that's you, 80.
So this is just a quote that came out in 2017, and so you can see eastern Washington, and you can also see Alaska. And so whether you're in a remote Alaskan village or the rural South, the factors involved in rural health disparities are not just something that our physicians can deal with. We need to figure out how to use data to target resources and interventions to make a meaningful difference in improving the health of rural America. So this is one humble solution. Go ahead, Amber.
So how did we start? Well, Kelly and Pat started it for us in Stevens County. Kelly was the champion in our area that took on conducting a gap analysis and facilitating meetings with our community. I onboarded with the team when we were kind of in the middle of getting things up and running and got to be part of large community assessments where Kelly had reached out to home health services, nursing homes, the ambulance, rural resources, anybody and everybody you could come into contact with in our community that might have some say in this patient's health care, and gave them a chance to tell us what do they need, what are we missing in our community. And we met on, I think it was Zoom, it was 2020, we met on Zoom and had follow-up calls with these people, and we had wonderful buy-in from the community, really good participation, lots of ideas, conversations about those ideas, meeting again in 30 days to see, who else had you brought to the table, please come next time and bring your friends, who are we missing? And then what do you want? Are we not only relevant but relatable to what's needed in our community and what people will accept in our community, because we are a closed community who has that mistrust of outsiders coming in the medical community.
And I would just add, as we go through all this, I really support you in thinking about the communities that you come from and who you would bring to the table and who you would invite and what unique things that your community, you might hear from your stakeholders about what would make you relevant.
And just a brief meta comment, this is so important that this is a grassroots movement. What are the needs of the community? How does that rise up to inform those of us wanting to provide services compared to the usual model where we roll in and go, how can we convince you to take part in our services? And then if you don't, it's your problem for not doing so, as opposed to recognizing we failed to identify the true needs of the community and how we could best meet those needs.
So Greg, you want to do the tele-PC model?
I can. I was thinking Amber would, but I'll be glad to.
She said you would.
Oh, okay. Okay. And you've already figured it out. When 80 says jump, I say how high. So what we did is we really looked at how the model would work. When we actually do the interactions, we have a local provider who makes the referral. So right now, I should have clarified this earlier. What we're talking about now is a model that works to 2 critical access hospitals. We're not doing home-based, facility-based, or other types of community-based palliative care. This is for people who are admitted to Mount Carmel Hospital in Colville or St. Joseph Hospital in Chewelah. And so the providers there wanted to know, how can we get inpatient palliative care consults, especially for the patients where we're deciding, do we transfer them to Spokane or to Coeur d'Alene or something? Maybe they're better off staying here near their families. Maybe they're ready to transition to more of a comfort-oriented treatment plan and not go through all the procedural interventions. And the hospitalists and others said, we would like help working through the goals of care discussions and really discerning what is best in terms of goal-aligned care. So the local provider makes the referral. They enter the referral. Typically, it's Amber who takes it out of Epic, which is our electronic record, and she kind of discerns, okay, can I and Gretchen, the palliative care people in Stevens County, manage this on our own, or should we bring in Gregg and 80 so we have the full interdisciplinary team? In the early days, it was about 40% they managed on their own, 60% we did the full Tele-Palliative care team. It evolved over time to where that was flipped, and now they're managing about 60% on their own, and about 40% they'll bring 80 and me into the picture. And then the other thing, family and friends. So when we have the full consult, Amber and 80 spend a lot of time, and Gretchen spend a lot of time really communicating with family. How do we get the relevant players here who can come in? And early that was trickier because there were a lot more visitation restrictions because of COVID. But we've had people from Canada, we've had people from multiple states, Hawaii, a lot of people throughout Washington. You know, even though the families in Colville, the son and daughter might be in Spokane, that's only 90 minutes away, but that's a big deal for a family meeting. So we set up a Zoom meeting that 80 and I come in on via Zoom. Amber and Gretchen are often in the room, or maybe Amber's in the room in Colville while Gretchen's in Chewelah, and since she zooms in, it's a blended model in person, but the in-person part is so essential. We'll talk about that more later. And then we come in, and usually 80 is the MC. She kind of coordinates everything and facilitates the conversation, and then we go from there. Anything any of you want to add to that before the next slide?
Just that we have developed criteria of what constitutes a hybrid telehealth with the physician coming in, and criteria for how you make that decision, and then what constitutes a local consult. So if you're interested and end up doing this model and contracting with folks who are outside your community, we're happy, and then we'll have our emails, we're happy to email you the criteria that we developed about what's a local versus a hybrid model.
I think one other piece to know is who is going to set the equipment up. Might seem like a detail that, oh, anybody can set it up, but have somebody assigned to set it up and to take it down and to clarify. So because we have chaplains in-house 7 days a week, we pinpointed a chaplain to be that person to set up the equipment, and also to stay in the room so that both Amber and the chaplain can reflect back. What did you understand about this call? What was important to you? What stood out for you?
And I appreciate you mentioning that, Kelly, because Gretchen is palliative care certified chaplain. There are 2 other chaplains that participate a lot who aren't palliative care certified, but they practice palliative care at a very high level. And it really, the entire spiritual care department is really fully bought in. So let's see.
Go ahead, next slide. Amber's going to do this one.
Yeah, go ahead, Amber.
So we started as a pilot program, and just to give you a little background on Eastern Washington, there's approximately 75,000 residents in 3 counties. Stevens, Ferry, and Pend Oreille County, they're big counties geographically with not very many people. Like Kelly mentioned, 25% of our population currently is over 65, and it's projected to be over 50% in the next 10 years. And as Gregg mentioned, one of our big goals was to reduce unnecessary transfers. A lot of these people, because we're critical access, are being stabilized and shipped, maybe before they were ever asked if they wanted to be shipped. And in the middle of COVID, that may not have just meant Spokane. That may have meant Kootenai and Coeur d'Alene, Seattle, Wenatchee. And so we are seeing these huge transfers happen. Best medicine is local. The people in our community trust local people in our community, and they want to stay there. And then we also were able to increase family involvement and presence. We brought Zoom in. We brought conference calls in. We brought families into conference rooms because they couldn't go in the room because of COVID, but they could wave at them through the window right before we had our discussion. And so we got really creative. And then the local or virtual piece is kind of what Adie was talking about. After doing a year's worth of consults, we really went through each one and said, did we do tele or local on this and why? And we came up with a list of reasons why. I usually would ask for Gregg and Adie's help, and then the other cases locally where Gretchen and I could handle, and being able to discern which way we went with that.
Go ahead, Gregg. So Kelly, here's you, 6-month SWOT analysis. And so, here's our findings.
So, with the analysis, I didn't start with the community analysis. I wanted to start with getting to know my team and to identify what the educational needs were of the team. And so that's where I began, and the greatest challenge was in educating the physicians, because they've been doing their thing forever, and I'm going to come in and tell them, oh, now we have palliative care. And of course they say, well, I know how to do palliative care. I've been doing palliative care. So it's, you're shifting a culture. And to get them to come to a place of buy-in and of respect and of invitation, that's sort of the progression. We had, let's see, I can't even read that.
Is that better?
Yeah. So we identified the practices of our interdisciplinary team, and we as a team, one of the pieces was, well, how do we meet? What do we meet for? How many times do we meet? When do we meet? So we coordinated with existing IDT meetings and found a time when everybody had done their rounds, when patients had received their meds, when patients had eaten, and we have our first IDT meeting on Mondays around 1 o'clock and on Fridays around 1 o'clock. So we can project into the week, and we could look back on the week and project over the weekend what might be those things that we need to pay attention to. And then once a month we have a team meeting, and in that meeting we can either unpack cases or we can provide other educational opportunities.
And I'll just comment, those IDTs are really robust in that they involve case managers, nurse managers, pharmacy, a lot of people who are not a part of the palliative care initiative per se, but whose work really is essential to delivering high quality palliative care.
We had PT and OT, and their contribution was really quite profound for us, as we especially talked about disposition.
And let's acknowledge Angela, the activities director.
Right.
She is amazing, and she really gets into what sort of physical activities, cognitive activities gives patients a sense of meaning and purpose, and really raises, I think, the holistic element of the care.
And so these are just some of the foundings of the original 6 months. As I'm reading them, I'm sort of chuckling, because now that we're 2 years into it, a lot of these have been resolved and are less applicable. But maybe that one comment about PPEs and is that Gregg and I, because we were coming in from our homes, we didn't have masks. We didn't have PPEs. And so it was really, the whole Zoom call actually removed some of the boundaries that traditionally were occurring when it was in the hospital setting. The other piece of it was that we were finding that for some people that had great discomfort with the hospital setting, it was easier for them to talk to us from their living room, from their front porch. And so I, as a social worker, always felt like I needed to be in real time with people and read all the nonverbals and all that. And I was very surprised to see the level of intimacy and personal disclosure and vulnerability that occurred via the Zoom calls. And Gregg, I think you...
Yeah, I first became aware of this through telepsych. I was really skeptical because you're thinking, you're talking about things that are so deeply personal. Don't you need to be in the same space? But in many instances, what they've learned is people feel less inhibited talking to somebody on a screen than they would in person. If, whether they're less likely to be judged, whether it's just less self-conscious. I have been blown away at times by the intimacy that has been able to be accomplished on these virtual interactions.
So this next slide, and you can see how these virtual interactions occurred. So maybe Amber and Kelly can talk to you about the different iterations and how we ultimately came up with this model and how much it costs, because I think that's important if you're thinking about doing a hybrid model.
So the one on the little eeny weeny one, I guess it's on your left. That was the initial piece. So we purchased an iPad and we thought, oh, we're going to need to have an iPad that can be on something solid so that the patient isn't trying to hold it or somebody's not trying to hold it up to the patient. And so we got these gooseneck things and we thought, oh, we're brilliant, right? Oh, we're just so with it. And boy, did that create some problems because they're not long enough to go up and over a bed when a patient can't sit up or can't roll over. It's very difficult to hear, and for some, very difficult to see. And the camera capacity was just a little channel. So you didn't know who else was in the room, like Amber and Gretchen in the room with the patient. And so they came up with...
New and improved. So usually Gretchen and I were the ones who were, wheeling this in and, so a lot of our patients were COVID or in ICU. They have BiPAPs running, the machines are beeping in the background, they're in isolation, and there's so much noise. We ended up pulling it off the little stand and we're holding it up so the patients can hear. And so we knew we needed better sound and we knew we needed better camera, and those were our two huge things. And so one of the chaplains on our team is really tech savvy, and he worked with our IT department, and we ended up getting wide angle webcams. And they have a light on them. When they come on, you can pan the whole room. And so you can see that he has 3 family members with him, the nurse is there, and you can actually see the patient. And then we were also able to get a microphone and speaker combo with this huge extension where we could literally set it up on the patient's chest if they were having trouble hearing us. You could set it on the bedside table, and it just really opened up being able for the patients to hear Gregg and Adie, but then also Gregg and Adie being able to hear the patient without me translating, back closer to the speaker. Lot bigger screen, just the quality was better, and it really enhanced the quality of our...
And a brief anecdote on how Nicholas came to that was we had one where we had the iPad on the gooseneck stand, but it was through an interpretive service, and they brought in the interpretive device, and Nicholas was like, that equipment's so much better. Why aren't we using that?
Yeah.
And the other thing I'll say is think about your unique needs. At St. Pete's, where I do most of my work, the gooseneck stand actually works well, but I'm not doing an entire interdisciplinary consult. I'm at the bedside with a patient, usually by myself, maybe with a nurse or a social worker or a chaplain, and it's really just for the family members. And we're rarely doing that with people with high-flow nasal cannula or CPAP or BiPAP. Once you're doing high-flow nasal cannula, CPAP, BiPAP, it really complicates things because of all the noise.
And the other thing I would say that we learned is that you can have closed captioning on Zoom. And so, in those rooms where high flow is happening or allowed BiPAP, we were able then to do closed captioning. And all of this is HIPAA compliant, by the way.
Yeah.
So, next one, Gregg.
Yeah, I am.
So we're going to, you're ahead of me. So we're going to follow a case. And this is a case that Amber called me and I mentioned yesterday, if you were there, about sort of dual roles that rural communities have. And so I asked Amber, well, is this a patient you know? And she said, yeah, I barrel raced with her in the rodeo. So she already knew this patient. So Amber, you want to sort of walk us through your end of it?
Yeah, so this case started for me at 7 o'clock in the coffee stand in Colville. And like Adie mentioned yesterday, that when someone in our community has cancer, our whole community has cancer. And this was a young patient who had a really vibrant social media following and, posted she was in the hospital, had a ton of support. And so I go through my coffee stand with my name badge on, and they're like, take this to her. And, so I start my day that way. And I get there that morning, and there's a referral, a palliative care referral in for her for pain management, goals of care, patient support, and advanced directives. And everyone's kind of like, oh, you're here. Oh my gosh, thank goodness you're here. Because she's young. We all know her. She's very involved in our community. There's no beds anywhere, so everyone's stressed about what to do to care for her. And so I instantly reach out to Adie, and and she says, do you know her? I said, yeah, I barrel raced with her. She's at law enforcement in our community. Our whole community's gone through this with her the last 2 years, and she hasn't been doing well. And so my need at that point was, as a nurse, but also as a community member, how can we serve her in this community? And for me, that was to bring Gregg and Adie in.
So we came in, and at this point, she really did want to pursue continuing medical care and all possible. She had young children, and so she was feeling that she wanted full treatment. And at that point, she did make a transfer from Colville to Spokane to get cancer treatment. Fast forward a couple of months, and Amber calls again.
About 3 months later, she had transferred back from Spokane to our facility, basically for comfort care. And in the interim, we had done advanced directives with her. Gregg had put her on some medication for bone pain. She tried treatments in Spokane, and just nothing was working. And so she wanted to come back home and be closer to where her family could visit her. And so we were consulted this time just for support, just how to support her, how to support the staff through what was coming, because everybody knew that this was a battle that was only a matter of time.
And when we talk about what's the one small thing that we can give a patient, what they want at that moment, and what she wanted was assistance in talking to her children. And how could we help facilitate this? And she was very engaged throughout the whole thing. She's taking notes. We're having this conversation. She had a notebook during the consult. And I guess for me, as the outsider, I was so profoundly touched by Amber's ability to be present as a nurse in the room, and then to hold the relationship with compassion outside the room. So thank you for that. Yeah. Anything else to add to that?
One starfish at a time.
Yeah. So go ahead, Gregg or Kelly, anything to add on that one? Can you think of?
Not on that one, and I
Okay.
just want to head to the next slide.
Oh, go to the next slide. So Gregg mentioned that we're starting to get word of mouth in the community, that people have had a consult with us, and then a friend of theirs says, oh, I want to talk to them, or they've come back with another family member and said, you were here for this family member, and now I want you here for my spouse. And so this is just a sample letter, which we don't have to read, but we have gotten just, one of those happy folders of bucket letters that on the bad days we pull out and we want to read.
Yeah.
So.
This is just some quotes from local folks. So the first one on the left is from the Chief Administrative Officer of the Critical Access Hospitals, and he had a quote that I really liked. We know we can't hire a palliative care provider and social worker. Our rural physicians are jacks of all trades, and here's the quote that I really loved. We don't know when we need you until we need you. So the idea of having access to those resources virtually kind of in real time. Now, granted, we're not 24/7, we're Monday through Friday business hours, but he doesn't have to plan ahead to hire somebody to come up from Spokane on Wednesday if he knows that if something comes up on Wednesday, I can reach out, and if they can't get to it today, tomorrow. And then the second one is from a long-standing RN at the facility. She said, you invite trust and intimacy in a community that is conservative and not open to change. Their real point was kind of what, One of my friends in Missoula says, you know, up in the critical access hospital there, they consider Missoula the big city and they don't welcome us. You don't want to hear what they think about Seattle. And so if we come in with this sort of arrogance, we're from the big city and we have this expertise to offer you, that's not very welcome. And so the idea that we come in with humility and meet them at the individual level at their place in the process, that really changes the dynamic a lot. And then finally, one of the charge nurses, he said, we're used to being independent, hard for us to ask since we come from a culture of self-sufficiency. But you've shown us there are limits to independence. And you may have heard Adie talk a little bit the other day about the tension between safety and independence. The children are worried about their parents' safety as they start to see physical decline. The parents are still saying, we want to be independent, and there's this tension. And she names that during the consult, and we'll come right out and say to them, we're navigating this tension between safety and independence so that we're naming where that tension lives and what they're experiencing in a way that helps them kind of understand how we can better support them.
So there's some lessons we have learned in doing this. And the first and foremost is a Kelly, or a clone of Kelly, which is the local champion. And as you sit here and think of your own communities, it might be you, it might be your colleague, or it might be someone you've yet to identify. But it is critical if you're going to do a palliative model that is a hybrid, or to start any sort of palliative care, you have to identify a champion. And then, Kelly, spiritual care support. It's been crucial for us. So you want to talk a little bit about that?
So the support through spiritual care, how many chaplains are here? Okay, so fair amount, right? Spiritual care, of course, is there for the patient. Of course, is there for the family as they navigate the slowing down of their usual way of being in the world. And the other piece is spiritual care is vital for the team. And this is hard stuff to carry. You're navigating your world, your work life, which is where you spend much of your time, in this emotional pocket that is intense. And we all need a time to just sit back, be grounded, and cry, or get angry, or just stare at a wall, right? So thank heavens for chaplains like Gretchen and the other chaplains we have in Stevens County. They are grounded, loving, sincere people that act with integrity, and I so appreciate these chaplains. I think the other piece, too, is the rest of the care team. When you're in a situation where you feel like you have done your best, but your aim really is to get that person better, but they're not going to get better in this world, they'll be better in another world, if that's your background that you believe. To have a chaplain be there for you, too, when you come to work, to know that you count, that you are important, that your organization cares for you enough to put somebody with boots on the ground that will care for you, that will hold your hand, that will take a walk around the block for you, is invaluable. So I'm so grateful to work for an organization that has chaplains.
Mm-hmm. And as someone who lives in the city, yes, there are people that have real spiritual identifications and church communities, but I've really been struck in Stevens County that the churches are social service agencies in a much larger way than my experience in Spokane, where we have social service agencies. And so as we do our patient's background and their strengths, this is always a question we ask, is do they have a spiritual community? Because it really has been a critical component in providing quality care. And Amber, why don't you talk about how we get a referral in the hospitalist?
Yeah, so our critical access hospitals have hospitalists on site 24 hours, and they're usually the only doc in the building. And so that's where most of our referrals come from. And as Kelly mentioned initially, there were some physicians who didn't want to use palliative care, didn't understand it. And so building relationships with them was huge. Gaining trust from them was huge. Going to the nurse managers and talking about them and having nurses start to put nurse-driven palliative care orders in was a really huge step for us as well.
And I'll just embarrass Amber a little bit. She has made such an incredible difference because when she started with the program, she was not palliative care certified. She didn't take long to do the work to become palliative care certified. But more importantly, she showed up with grace, humility, in the right place at the right time, built relationships, and there is such a deep sense of trust and confidence in her that it really makes a huge difference. So all that to say, if you can have somebody on the ground who is recognized, respected, trusted, and there can be dialogue, it makes a world of difference. So as a physician, I really don't have much of a relationship with most of the docs. They know who I am. I don't know if they like me or not. We really haven't met. But they deeply respect, care for, and trust Amber, and that has just made a world of difference.
And that certainly came through this morning when I heard you talk about the ED and the relationship you've developed with your staff as well. So again, if there's anything I can highlight is relationship is what I've learned. That's what it's all about. So Gregg, you want to do the next one? It's a busy one.
This is we actually debated taking this one out because it's almost incomprehensible. But there are three elements to it that we thought made it worth keeping. And the first is, if you look across the kind of horizontal axis, 3 different phases of the development. So you start in the building phase. Once you get up and running, you're in the evolving phase, and then to try and hopefully get to the thriving phase. And so the tiny print in there talks about that. And then the domains that you need to think about for each of those. So as you move down vertically, you start with palliative care leadership. We talked about the importance of a champion, but you also need clinical leadership, the clinical team and the palliative care skill set. So I spent a lot of time communicating with hospitalists. Amber and I spent a lot of time talking how much, because I don't write orders in these charts, so we have to build the trust that if I think that there are medical management needs, how do we respectfully convey that to hospitalists in a way that they welcome it rather than feel pushback because who are you to tell me what to do? That's, again, where the relationship building counts. The advanced care planning processes, again, you need to go through building, evolving, thriving. Care coordination and collaboration with community services and supports. Adie's an amazing social worker, but she doesn't know the Stevens County resources the way the care management team do at the 2 hospitals there. And early on, we had to navigate some boundaries there because there was a little, I've seen this in just about every palliative care program where case management and the palliative care social work sort of have to figure out where's my lane, where's yours, when is it okay to cross over? And it can go both ways, stay out of my lane versus, oh great, I can have her do the work instead. So it's really important that that goes on. So Adie spent a lot of time with case management to make sure that those things were clarified as much as possible. We, as often as we can, have the case managers actually in on the calls. And that makes a big difference because we can often then say to Karen or Heidi, you know, okay, so can they even get home health where they live? No, they live up near the Canadian border and the home health agency doesn't go into that area. There are people that live that remote. I still love your quote, Kelly, about it. Some driveways take 40 minutes. Yeah. Moving down into community awareness of palliative care, ongoing community awareness through both word of mouth, as we've talked about, but then if you really want to move the program, actually having initiatives where you go to the area agency on aging, you go in the community I live in, we go to the retirement communities and we'll have talks. And then finally, availability of formal palliative care services, being really clear, when are you available, when are you not available, because you don't want people to think, okay, I want palliative care, and then you're not there to help them. Under promise, over deliver.
And I just wanted to say that this process has been about 3 years, 3 to 4 years in Stevens County. And what I've observed in on the panel, and that's a family member calling me. Hold on, we'll just make them
I'll
wait.
just butt in here real quick.
We'll make them wait.
One thing that has been really valuable for the Tele-Palliative process is that Adie will call us all afterwards and we have a debrief. What went well? What did we learn? What maybe should we have done a little bit different? So that's been very, very helpful for us. And the other piece that I want to share is I want to give a shout out to Pat Justice and at that time Raleigh Bowden, because I would still be hiding under my desk if it weren't for those 2 women. So thank you so much for your guidance, and I learned huge amounts of process pieces. And the tools that were available through their websites, through CAPC, it's incredible. So if nothing else, get in touch and take advantage of those resources.
So now that I've gotten rid of my family,
Is your family member okay, 80?
Yeah, I think so. We'll find out. I have a funny story. I had pneumonia recently, and I was delirious, and then my daughters came to me afterwards and said, "Mom, we think we have to have the conversation about aging in place." And I goes, "What?" And they said, "Mom, you always say it's always too soon until it's too late." And so, you know, that was one of them checking on me, I'm sure, before I drive. Anyhow, but
They haven't taken the keys away yet?
not yet. But anyhow, what I wanted to say about this is that it took Stevens County 3 to 4 years to get here. And I think one of the things I've observed in fledgling programs and when you get started is you want to be at the end point. And you have this image of how wonderful it is. And that I really want to support all of you and being right where you are at the moment that you are, and you will get there. And don't push yourself to go too fast, because if you jump through steps, you're going to have to backtrack and get there. So this is what you're seeing is the culmination of 3 to 4 years of work. So the next one, Gregg.
This is on the stats. And Amber, do you want to talk about these?
Yeah, sure. So our first year, we started in May, and Gretchen and I actually both onboarded with this program literally like within weeks of this. And so from May to December in 2021, we had 72 telehealth consults and 68 local. And so we had a 52 to 48% split. This year so far, from January to the end of September, we've done 47 teleconsults and 87 local. And we've had a huge shift in how we utilize Gregg and 80 and how the hospitalists that we work with, the ones that have chose to sit in, how I hear them model Gregg now and how they start their conversations. And so they're building their own palliative care language and confidence.
Amy or Adi asked me this morning, how do I hold on to hope? And one of it is the young doctors are trained so much better than my generation. Their communication skills, their understanding of patient-centered care. I was deep into my career before I got to the point many of them are in their 30s already. So it's really gives me hope.
So what next?
Question?
Oh.
I just wanted to ask Amber, you mentioned the hospitalists. Are they actually coming into the teleconference and being part of it?
They're always invited.
Let me repeat that just because we have some people zooming
The
in.
question was, do the hospitalists join in on the family meetings or the goals of care conferences?
Okay, go ahead.
They're always invited. I would say maybe 30% of the time they participate. It's usually some routine doctors that will sit down with us. Probably more so at the little bit bigger hospital. The other hospital, the hospitalist is also the ER physician. And so what they say to us most often is, "Oh my God, you guys just saved me 2 hours." You know, they're so excited that they didn't have to be there. We have had general surgeons sit in goals of care conversations with us who were really invested, dietary, pharmacy, rehab, activities professionals, really good buy-in from our team.
And I will say, when a hospitalist is there, it's actually much better for me because we have a back and forth too. I'll turn to, well, Dr. Kilgore, would you explain, the current treatments and where that might go? And he can speak with an authenticity as the attending physician that then I can take it to a different level of, okay, now let's talk about how things might look moving forward. And so they like to participate when they can, but their lives are busy. So if we can save them 2 hours, they like that also.
We also have residents that go up to rural communities every now and then. And so this has been an education opportunity for them because we've had them sit in on our family meetings and our consults as well. So Gregg, the next shot.
Yeah, and 80 cleaned this one up. My rear end shot of the cow was not quite as nice as this one. So she intentionally picked this cow with a full udder where, is this cow walking off into the sunset or going back to the barn to be milked? Why did we choose this image? Well, in full disclosure, sadly, in these tumultuous financial times, we were notified that this telehealth program was going to be shut down. Now, if you haven't figured out, Kelly Corcoran is a strong personality, and she has That's a good thing, Kelly. She has been an incredible champion, and so there are negotiations underway where I do believe we will likely be able to maintain this. But what it's taking is some, it's no done deal, but you know, what's the old Jim Carrey quote about, so you're saying there's a chance. We're still working on that. But the idea is that just because one source of funding, one administrative home decided you're not generating enough revenue to satisfy us, we have other ways of doing it. And so the what next is sort of, what are we wishing for? 80? Amber? Kelly, what are you wishing for?
So this is the wish, worry, wonder question that we often utilize when we have family meetings and we talk to patients and their families. So I wanted to ask you what you're wishing, what you're worrying about, as we had our last official consult October 13th. So tell me, what are you wishing for, worried, and wondering?
What I worry about is you two. Because you're, in a sense, reinventing yourself, perhaps in another location, hopefully not. What I hope for is that the channels that I've been discovering are actually fruitful, and that you will still be on board, just under different words and different agreements and blah, blah, blah. The other piece I hope for in that is, with your leadership and your guidance, just as Dr. Kilgore has learned how to frame his approach with the patients, the rest of the team will do the same. And that we have homegrown physicians or nurse practitioners that will step up to be a palliative nurse practitioner or a palliative physician or a palliative specific licensed clinical social worker. That's my hope. My dream.
How about you, Amber? Your wish, worry, wonder?
My wish is that we got to keep doing what we were doing because it was amazing. I grew up in this community, and so it was really special to bring this back. My worry is that we won't continue our work, but I know we will somehow.
Let me rescue you for a moment, okay? So what I have seen, whatever the next step is, and the next, I'm not sure. I'm open to being surprised, as I said to Pat. But there has been a significant culture shift in this community. And what was not a palliative infused community is now. And it happens from this, the CAO all the way through dietary folks when we walk through the halls. So my joy, my bliss from the last year and a half, 2 years, has been that I know this is a lasting legacy that I entrust and have great faith that Amber and Kelly and Gretchen will continue to keep the conversation going. I'm worried that you'll get burned out, and so they have our phone numbers to get a hold of us. And I'm wondering for all of you, as you think about your own communities and your own resources, how you can think about infusing a palliative culture wherever you work. It is possible.
It's not only possible, it's almost essential, because there are not enough specialty palliative care consulting people in any discipline to meet all the needs. So ultimately, making it so that your nursing assistants, your housekeepers, your nurses, everybody in the hospital has a higher level of that, so-called primary palliative care makes a big difference. And one of the greatest compliments I ever felt was the ICU doctor who told me that the palliative care team in our ICU was the biggest culture change he'd witnessed in recent years. And he said, not just the people you see, it's when you're not involved. I see the nurses, I see the respiratory therapists, I see others treating patients in a manner they didn't before palliative care was on board, because they've learned by watching you. They've learned by listening to you. And so part of my wish, worry, wonder, maybe this is more, what are you hoping for? I'm hoping that people at the site of care have such highly developed palliative care skills, even if they're not palliative care specialist that the patient's needs are met, because ultimately, it doesn't need to be me, it doesn't need to be 80. If the patient's needs are being met, that's what counts. And I'm honored when I can be the one who helps get those needs met, but I'm even happier if those needs can be met without them needing to reach outside the community. So if that's a possibility, I'll celebrate it.
So last slide.
I'll just tag on one more piece. I've had, before this announcement, I had 3 physicians approach me and say, when can we get this into our clinics? When can this be part of the ambulatory or outpatient scene? And so I was really excited. It's like, I get to expand. And so I'm just going to go with the expand piece, and we'll just expand other contracts.
So this last picture is a consult. It's, you know, you have Gretchen and Amber and a patient who is actually Nicholas, a chaplain. And then you have Gregg and myself zooming in to the meeting. Here.
And notice who's talking.
I think it's Amber. You just can't see it's behind the mask. Here are our addresses. We really do want you to use us. Again, Pat, we should have put your address here as well, because she is our statewide resource in the process. But please, if you get in touch with any of us, we'll make sure you can get in touch with Pat as well. We want to give you a chance to ask any questions. I think we have like a minute. So you want to come over to the mic, please?
3 on my watch, but I'll trust Barb.
Okay.
I want to underscore what Gregg just said about thinking about all the members of a care facility, and I want to say that to support what you said, so the Palliative Care Institute developed a training program for the staff, like the kitchen staff, the people who serve the food, because it's not just them watching you, they need their own training.
Yes.
They need to develop the language and the protocols, and what you then find is they begin to see themselves as part of a care team, so the whole milieu becomes a caring milieu.
And there actually was a study that said when they looked at who patients talk to, it was housekeeping.
Absolutely.
More than their nurses, more than their physicians or their social workers. They spent more time. Well, housekeepers are in your room, right? And there's just this conversation that goes on. So I love the fact that there's training.
Thanks, Marie.
Yeah.
Hey there. I'm an RN in the Dayton area, so I also provide care among the cows. And I just wanted to, those that are starting out in a rural program, I just want to encourage you that I've had the wife of a patient was in their home who said, why don't they have this in the Tri-Cities? My sister needs someone like you, and why can't she find someone like you? We have such strength in our small communities that you described and so cared for. I mean, Teresa will get calls from the police. This local schizophrenic who we know and care for is kind of spiraling. Can you come talk to him? You know, I can call our pharmacist on a Sunday and say, this chemo patient forgot to pick up their meds. Could you go in and get them? Oh, sure. Would you like my wife to drop them off, or would you like to come and get them? You know, I can call the local bus service and say, have you seen this patient today? Because I'm kind of having trouble finding him. Oh yeah, we dropped him off at the store. He's fine. You know, there's a lot of things that we have that I see every single week that you don't have in the cities, so you'll be fine.
We want to thank you, and I want to thank you too for being caretakers of this.
Yes.
Thank you.
Oh.
Wow, look at this. My group's got the Rotten Tomatoes. They're ready.
Nice. So I know people are still getting settled, and I'm getting the stink eye because we have to follow the dairy cow people, and what a great session that was. Oh my gosh. So we go from heartwarming to nitpicky stuff about hospice regulations or urban legends about hospice regulations, right? Welcome everybody. I'm Barb Hansen. This is Laurie Jackson. I think you've already met us, or you will during the course of this hour. So we're just going to jump in. And I will say this was Laurie's idea, this title, because she's on her third agency in, I don't know, 6 years. I'm teasing her now. And she says, there's all these questions and nobody ever has answers to them. And I said, let's do a session about that.
Do you ever have a question, like you're in a leadership meeting or somewhere and wait a minute, is this the way we should do this? Yeah. What's everybody else doing? So do you do what I do and you contact Barb? And then she says, let me send out a listserv.
Yeah, let's see what everybody
does. Everybody else is doing. Well, there are plenty of those things that kind of come back with I don't know, what are you doing? I don't know, what are you doing?
That's right. Or the surveyor told us 12 years ago we should do it this way, and so you do it that way. So anyway, these are our objectives. We're going to talk about some of the common challenging operational issues, the many and varying factors that go into determining how a hospice decides to do stuff, and also how your palliative care program might decide. And I promise we'll tag team it. We haven't really practiced this. So, and then new staff who come to you from another hospice, and they think they knew what hospice required, but it was really the policies of that hospice, and now you've got different policies, and it's a little bit crazy making. So I talked to one hospice director once who said, I'd rather hire a person from the hospital than somebody who's worked at another hospice, because I can teach them how to do home visits and to do hospice, but sometimes those folks who've worked elsewhere have preconceived notions that are hard to undo.
We also know that this is the last seminar of the day, and we want you to leave on a happy note. And so hopefully, one of our goals, although it wasn't a listed objective, is for you to have fun here, to get some energy for your drive home, whether it's a 12-minute drive or longer.
A 7-hour drive.
Or a 7-hour drive.
Yeah, that's right. So if you can't see this cartoon, I know it might be kind of hard to see. I have a stupid question. There are no stupid questions. That's ridiculous. If there are no stupid questions, then what kind of questions do stupid people ask? Do they get smart just in time to ask questions? Were you going to ask me something? See, now there's a stupid question. So our disclosure, we're not being paid by anyone. Laurie asked me, why on earth are we the last session of the day? That's a topic for another time. And all photos used are licensed by Creative Commons and have not been altered, or they're personal photos. And we don't mind questions in between. We don't mind being interrupted. Yeah. I think some of these are mine, and then I'll turn it over to you. So for those of you who've been doing hospice since 1983, anybody been doing hospice that long? I started in 86, but the Medicare hospice benefit already existed. But this language is in the 1983 final rule that hospices are required to provide virtually all of the care that is needed by terminally ill patients. This is well before the relatedness, not related discussions began to happen in 2020. And they reiterated this position in 2019, that it's a CMS long-standing position that all of the treatments related to the terminal illness and any related conditions really must be covered by the hospice. And I've given you the link if you want to go back in the notes to look at that 1983 archival final rule. So, and the Medicare Benefit Policy Manual, Chapter 9, this is one of my Bibles, actually, that I use when people send me questions, and I get regulatory questions every day. This is one of those Bibles, and so you're always looking for the answer book, right? This is one of the answer books. And again, it talks about hospices being responsible for providing any and all services indicated in the plan of care as reasonable and necessary for palliation and management of the terminal illness and related conditions. So here's a true or false. Laurie, you take this one.
All right. what a little screen.
Here's the clicker.
Okay.
I know.
True or false? Call these out as you know them. It's okay if you're wrong. We'll teach you later. Okay, true or false? The hospice COPs clearly state which supplies must be covered and the amounts that must be provided. False. Okay, they clearly state which treatments are palliative and which are life prolonging. Are you seeing a pattern? Okay. The COPs clearly state which medications are palliative and which ones must be on a hospice's formulary. And finally, drum roll please, how a hospice should address the situation when a patient names an attending physician who then doesn't respond to the hospice within 3 days.
Well, no wonder hospice is hard. There are no answers.
At all. Oh, quick.
Can you see that?
No, I can't see that.
Okay, let me see. Okay.
We actually did do this before. So, I mean,
but it's been a month.
It's been a month. We did this at Oregon.
So these are just some studies that came out from the OIG, some reports that were released in 2019. Well, one in 2019. I'm sorry, I lied. 2021 and 2022. There were a couple different ones in 2019. The OIG is trying to get CMS to crack down on spending outside the hospice benefit. So your hospice patients who go to the emergency room, go in for outpatient therapy, are also receiving home health therapy, are getting physical therapy, are getting medications that should be covered by hospice. So it is like hundreds of millions of dollars. And hospice used to be this little benefit that CMS didn't pay attention to, and now it's, you know, a $1 billion industry. So there we go.
And I mean, this just further substantiates that you know why CMS loves hospice.
Mic drop.
We're just I remember David Brunel about 5 years ago or yesterday had some technical difficulties and he was super smooth.
Yes,
So,
he ad-libs well.
It's true. This just further evidence of the challenge. You know, CMS loves hospice because it costs less for better care, right? And so as we stretch the boundaries more and more, CMS is going to continue to come back with less and less, because there's a reason why they want us to be providing all of this, right? That's really what all this is. All the non-hospice payments over the last 10 years, there are a lot. The increases are substantial. For Part A, there are decreases. For Part B, there are increases, and they mean a ton.
And just go, we can.
And you get the slides. Okay, so, and because of all of this, it's hard to know exactly what to cover. There are other challenges as well. How do you decide? How do you make sure that you're consistent within your agency? So first, figuring out, is this what we should be doing? And is this what everybody within our own agency is doing? Whether it is the nurse that's in the rural area of the county, or the one that's in the skilled facility, or the other one that's in that same skilled facility. How to explain why it is you're going to provide certain things and not other things, and then how do you educate your entire staff on this? So it's a challenge. So then there's even more. Is the treatment palliative, or is it considered life prolonging?
Another shout out.
It's true.
Right?
Okay, are IV fluids palliative or life prolonging? Yep. Right?
It depends.
It depends. Which is the name of our underground program.
That's right.
By the way. And you see the rest. Enteral fluids, TPN. Okay. How do you feel about enteral fluids? How do you feel about them? How do you feel about them being palliative or life prolonging? What's your thought?
Depends.
It does, right? It really does. But how do you teach that? What's the line? Do you have a delineation for your team, for your patients?
Policies. so that your weekend or on-call staff can rely on policies for these decisions? Is it always case by case? That's crazy making.
What about TPN? Does your agency do you ever approve TPN?
We had one person who did on it for years, and no, we didn't make her stop to come on service.
You had a person on it for years and you didn't make them stop to come on.
My former program, we had this arbitrary policy, I'll say I inherited it, that said we would cover it for 3 weeks. And it's like, what happened after 3 weeks all of a sudden? And no nurses wanted to visit at, 3 weeks because they had to be the bad person to say, we're stopping this now. I don't know, it was just weird and arbitrary.
How about, I'm skipping around here. Oh, in the last couple of years, my curse word has been trilogy. Right?
Trilogy ventilators. Whoever, some programs don't cover them at all. Some are like, oh yeah, we cover those.
No problem.
Yeah.
How about?
Oh wait.
Oh yes.
What about the water, the special water needed for the trilogy there?
What about the special water?
Good call.
Do you carve that out? You'll cover the ventilator, but they have to buy the water?
Does the adult family home that is being paid by Medicaid have to provide this?
Right, exactly. There's an example of a dilemma, a hard question that nobody has the answer to.
How about thoracentesis or paracentesis?
How much? Again, my former program said, we will cover once a month. And then we had an insurance company said, but our patient needs one once a week. So if we cover 2 a month, will you cover 2 a month? There was like this negotiation going on, and it made no sense, really.
What about, have you ever done short course radiation or chemotherapy? Yep.
But hospices in the 90s and early 2000s hardly ever did that. So that's been a more recent, I think, phenomenon.
Okay. You want to jump in?
What do we have? What are you leaving me with? So as your program is deciding what you cover to sort of build this framework, you sort of ask yourself, if you're doing it as a trial, how long? If you're doing it for symptom control, like blood transfusions for weakness, how long do you do those? I mean, is somebody getting a blood transfusion once a week? And so if the patient has to try a formulary medication first before you'll cover the expensive brand name medication they really want, how long does that trial? How many, times do they have to try your formulary medication? Have you gotten this defined in policy? And again, are there limits on how long can a patient stay on TPN or enteral feedings if you cover enteral feedings? Again, my former program, you'll see why I'm not in that job anymore. No, we cleaned this up while I was still there. We had this policy that we would cover enteral feedings, but only if there was some mechanical obstruction for swallowing, like esophageal cancer. I don't know, that we had somebody with a different kind of cancer and they came to us with the PEG tube, but does that mean we would or wouldn't cover the enteral feedings? Again, it was just so arbitrary. And if a patient needs an expensive treatment or medication and they're willing to pay for it out of pocket, or they have an insurance company that will pay for it, do you allow that?
Have you run into that? We don't cover this here. Oh, that's okay. I'll pay for it. And how then does that address equity within your agency? When you got the one person that says, I've got the bucks, I can do it, and then the next person is on charity care. Yeah. Right?
Yeah, exactly.
We're coming up with all kinds of problems. What are the solutions?
I know. So I want to invite you to all look at your own programs and figure out who decides. Is it the hospice medical director? You figure out who it is. It's the woman in the blue tunic. That's what I think. Or is it the entire interdisciplinary group? Are they ever going to come to agreement? The nurse case manager, the ethics committee, if you have one, the staff, the patient and family. Who gets to decide all these coverage decisions? And again, if you leave it to a case-by-case basis, that's really challenging for your staff. Not just your new staff, but your on-call staff, your weekend staff, your Monday through Friday staff. Anybody want to share how you decide this? So how should a program decide and how quickly? So you have to look at relatedness and who is deciding about relatedness and making those decisions? Typically, is it the hospice medical director in most of your programs, or is it the entire interdisciplinary group?
Our medical director.
Medical director.
Diagnosis review at the beginning and writes a note that says that these items
Okay.
are related and these are not.
And what about if new needs for medications come up?
That really only, well, I guess it would depend on if it fit into one of those categories.
Right, okay.
Into those already listed categories, then it would have to.
So if it didn't fit into the already listed category, probably it was unrelated. Not necessarily case by case.
Yeah, then it really does fall into.
Yeah. And how do you operationalize this process? It's your medical director doing this 7 days a week? Do we have medical directors in the room who want to share? Has this made your life crazy? It's a challenge for those patients you admit on weekends, and the family wants to know what's being covered before they decide if they're signing the election paperwork. Yeah, you have to sort of have some sort of template or framework, and how quickly you can make these decisions. And again, what happens on weekends and holidays. And like I said, we had patients who the family didn't want to sign the election form until they knew precisely what we were going to cover, because they had other insurance that would, pay for most everything. So I don't know if you have anything you want to add to that conversation. But let's talk about supplies. It's your favorite.
It is my favorite. So I came from an agency in Central Washington where we did not cover anything absorbent. And a hospice medical director was adamant about it. It does not say that you have to cover that. When it talks about incontinence supplies, those mean the definition that in diving deep was catheter supplies as examples. So we did not ever do the undergarments of any sort, and that was just a long-standing. We all knew it. The community knew it, and that was the deal. Then I left that community, and I assumed, hey, this is how everybody should be, because it must be some sort of regulatory something. And I went down to Oregon and made no friends, because I said, hey, we don't have to do this. We're not going to do this. And in fact, the problem was not supplying, I'll just call them depends, but all the different kinds of undergarments, disposable undergarments and all, and covering briefs and everything that I never thought I'd think about when I went to seminary. So, our supply cost was $68,000 over what it should have been because of supplying those for the facilities that were taking advantage. So it wasn't just supplying them, it's we need 12 boxes for our one patient this week. And we, no joke, had our CNAs and nurses it was a menu, kind of a beautiful menu. What would you like? You're starting on hospice. Would you like shampoo, soap, toilet paper? Depends. How many? And they got to, no, it's free on hospice, right? So we had a lot of work to do, and being able to focus on what were first the requirements, and then what were some of the things that we could provide, made for a lot of chaos, and that was right as the pandemic was starting too. So that was awesome. And then I came to the Tri-Cities, and we got to actually have good conversation about it. What were we providing? Hey, there is a lot of extra supply stuff that we're doing. How do we provide supplies without tanking financially? And, if there are patients that can get on Medicaid, that's an easy win, because we supply those kinds of supplies if they're on Medicaid already. So if there's a family that's struggling, why not let's get them on Medicaid and really benefit them better? And so I'm pointing over here because this is the part of the team and the ones that actually have done all the work at Chaplaincy for that, for which I'm really grateful. But it has really helped me better understand that it's not very clear. No, you don't have to provide these things, but you better have a good rationale as to what you are going to provide and the why. And to take something away, back to what I shared yesterday, when you give something to a community or to your staff, to take it away is a real challenge. So you want to be really careful about that. And if you have more than one hospice agency in the community and you're doing things differently, that can be a selling point for either your agency or the other. Does this make sense? I know it's getting late in the afternoon. We're going to have some fun here in a minute.
I'll just say, there was a light bulb moment at my former program, too, when we realized we didn't have to order 17 brands of absorbent products. We could go with one brand in different sizes and have par levels that we took out every week, because we had adult family homes taking advantage, and all 5 of their residents were wearing products that we supplied. So that was an education process that we only take out like a week's supply at a time, and we get to decide what that is. And if they don't like the brand we supply, they're welcome to special order whatever they want, but we will supply this brand. And we weren't going to use, a bad brand that wasn't absorbent. We were going to do our work and stock something decent. But anyway, it was an education process with our staff, especially about par levels.
Yep. We had our own employee who had a parent that died on hospice, and this person came back afterward and said, what do I do with the cases and cases of undergarments that we never used, we never asked for, the team just brought them out? That's a challenge. And that's money down the tubes for the agency as well, right? Questions? Okay.
Comes in, the nurses hoard it. They actually take it in their car and say, don't tell anybody, I'll take it with me when I go.
Yeah, so then there's the donation thing too. What do you do about that? About donations that you get?
Do you have a policy on donations? Sorry, I should be. Donated supplies, because some hospices take them and some don't. And some send them, my program, we used to send them to the Ukraine. That was before the war in the Ukraine, but...
some programs have actually given them to other programs.
Yeah, I keep a list on my phone, and then I can just text families
places to get it, yeah. With infection control standards, you have to be careful about accepting supplies back.
Very careful.
Yes.
Yeah.
Yes.
People that they'll bring, we work as a critical access hospital, but people in the community, they'll just be like a Saturday afternoon or Sunday afternoon, and I got all this stuff, my husband or my passed away, and if you tell them we can't take that, they really hurt.
Yes. They want to see it get used. Yeah.
So, we're not supposed to.
Yeah. But if you can develop a list of who can provide, take it and give it out. Yeah.
Because it sold
Yeah.
that thing too.
Yep. I know.
They want to do something like that,
Do we have virtual attendees now? So we don't have to worry about the mic so much.
We found that when we reached out into the community to find out, hey, who will accept these, and whom could we send our patients and their families to get them? So again, we're not the person that's doing it, because let's say you graduate from hospice, let's say people that are preparing for hospice, we didn't want that to be the reason that they're either going on or when they're going off that it's hard. We found there were more people that were willing to donate than there was a need to receive them, and there was no place to do the drug deal.
The depends deal.
The depends deal.
And speaking of,
Okay, medications. Do you work with the PBM? How many of you are part of the health system? Quite a few? Okay.
You're not very proud about it if you are.
I know. Woohoo! Go team.
It's like...
Do you work with the PBM? You should raise your hand. There we go. Thank you very much.
Pharmacy Benefit Manager. They're like the triager of your medications, and they... Like Delta Care, there were several exhibitors here. Delta Care is one point.
If you don't have a pharmacist.
You mean on staff? Okay.
Okay. Do you have access to other pharmacy options? Okay. See, there a lot. Are we making you question? I'm making me question. Right? And do you have access to 340B pricing? Yeah?
Well, you're lucky. Yes.
I kept trying to be convinced down in Oregon that, no, you're getting better than 340B pricing. I didn't know what to say. Very interesting. Okay. And how does your program do at deprescribing? You do okay? Do you feel like you do okay? It's a lot of medication. A lot of this is all around that primary conversation of your goals, right? Of the patient's goals. What are you hoping to get out of this? What's your plan here? And a lot of these do fall into that bucket, obviously.
I'll tell you what, one program in Oregon contacted me a couple years ago, and they said, we do active deprescribing when patients come on service, but we have decided we're going to cover everything they're on, whether it's related or not related, because we realized we were spending so much physician and nurse practitioner time, clinician time, pharmacist time, nurse time, figuring out whether to cover something, that we decided it's cheaper if we just cover everything along with deprescribing. And then I had a question last week from a Washington program that said, is this an inducement if you cover everything? And I asked this question during the NHPCO regulatory office hours last Friday, and I said, what do you all think about that? And I said, I think the key is if you advertise that you cover everything, then it's an inducement. If you don't advertise it, it's just part of your process along with deprescribing, and it's to save clinician time because it's a time of workforce shortage like we've never seen before. But you don't advertise it, it's not part of your marketing campaign, then it's not an inducement, and no one could accuse you of offering an inducement because that's your practice. But again, you're doing it with robust deprescribing, and then some of those things that aren't related and probably aren't that expensive, frankly, you're just covering, just because it saves clinician time. So that was a decision. One program, they have an average daily census 250, 300. They just decided to save time. That's what they did. I'm not saying that, I'm not recommending that, I'm just sharing that information.
And would your clinicians know? I mean, do they understand? Are they part of the conversation about why deprescribing is important for the patient, not just the bottom line?
Yeah.
And that it relates to goals of care. Those of you who are leaders in the room may have had the challenge of folks saying, well, you're about the business and we're about the care. Yeah. I don't know if you've ever had that. I've been questioned that before, and I just want to make sure that we stay in business so that we can serve more patients, and I want to make sure also that our staff actually has a paycheck.
Yeah.
So that they can follow their mission and ours. Yes.
Along with deprescribing, we've actually had patients that we deprescribed and then they graduated because they were no longer.
Exactly. Yes. I mean, all of those medications aren't necessarily doing them any good anyway. There's side effects, and it's a pill burden for a lot of people, and you're eliminating some of that pill burden. So yeah, there are some very valid reasons for deprescribing.
Do you want to do true false?
Is this one mine?
I think it is.
Okay, another true false. Every hospice does things the same way. That is such a gimme. Coverage decisions under Medicare hospice are always the same regardless of which hospice is providing care. Of course not. Staff who have worked for one hospice will know how that hospice did things. Yes. Now that's true. They'll know how that, but they will come to your hospice and now think you're doing it wrong because the other hospice did it this way. When staff come to a new hospice, they may experience confusion about how the new hospice makes coverage decisions. Absolutely. Neither the old hospice nor the new hospice is necessarily wrong about how they make coverage decisions. And I could add another one here. There's a lot of gray area in the hospice regulations, right? Absolutely. Okay, let's talk about palliative or custodial care. This is sort of like the difference between a keynote and a plenary speaker. We need David Brunel to come up here and explain it to us, right? Was the patient already receiving this treatment or supply long before needing hospice care? And that's true with absorbent products sometimes. They're already on Medicaid. They've been getting a monthly shipment for years before they ever got their terminal diagnosis. And that's the example. And can you benchmark that issue? And then what is the standard of care by other hospices in the state? Because that's always what you're compared against, really, not just in your market. And that's where I'm happy to send out listserv questions. Do you, and here's some I've sent out over the past 5 or 7 years that I've been in this role. About incontinence supplies, coverage of enteral fluids, TPN, trilogy ventilators, all of those things on the list. I've sent out listservs. And when I share the results, I never include program names because I just want you to know here's what other programs said they do. And is it worth the hassle to even debate the coverage of something? Sometimes it's not, and you just have to look at the big picture and try to come up with a policy that makes sense. And so if you're going to consider a treatment palliative or life prolonging, of course you want to look at, are you managing a symptom and the patient is going to continue on their terminal trajectory? Are you providing life prolonging care that is going to extend their life? And you could still do that. In some instances, they want to live to see their child get married or graduate. I think most hospice programs, I know we kept a patient on TPN for that one time to keep them alive. And does it extend the patient's life indefinitely, and there's not like a goal that you're trying to meet? And these are just some of the ways you parse this kind of a decision. So when might it be the right decision for a patient to not elect hospice? Do you want to take this one?
Okay.
Yeah, go ahead.
Okay. A few of the times when it might be appropriate not to elect it. When they can't agree about calling 911? Yeah? Have you had that? It's not just us, right? When the family wants to be able to get tests done whenever they want. Lab work.
CAT scan, MRI.
When the patient or family want to continue, I love that or the family wants to continue on a medication that's not on your formulary. When the patient has a specialty DME item that's not part of your hospice program's DME contract.
Do you have to cover that specialty DME? Not necessarily. Again, that's a programmatic decision you get to make.
And then again with but we'll cover it. What are you going to do?
Yeah.
Just know how you're going to respond. I mean, a lot of this is in the question. These are not just meant to create more of a chumming of the waters, but for you to start thinking about, okay, what do we do? Because these are fairly basic issues.
And you could decide to cover the specialty DME item if it is managing a symptom that literally cannot be managed in any other way, or it's a quality of life issue that you agree to cover that, but you don't have to.
Absolutely. So do you have limits on or goals for your daily costs for DME supplies, medication? And do you know where you might fall in there? I know you do.
We might be asking the wrong crowd.
Maybe so. Could be. Okay, let's share. Are you going to do the cards?
Yes, let's do it.
Okay, this is considered low threat participation. Barb is now going to play Vanna. And we want to know whether it's your answer to the cards or you can make up your own. In Oregon, this was the most fun that we had. And we're giving each table a card for you to answer. If you want, you can answer that as a table. We'll give you a minute to look at these and to share what your response is as your table. Or if you have another hard question you'd rather share and get the input from the rest of the group, that's fine too. So think about what hard questions challenge your program the most, what are the most challenging for your staff, and where do you go for the answers? I go to you, because obviously I have 0 answers. Okay, I know that we also, a lot of systems will regularly go to an ethics committee for consult when there are challenges. Does your agency have an ethics committee? Yeah? That's good. Is there a front table that's have you looked at the card, or do you have a challenging question that you want to answer? Go ahead. Yep, perfect. What is it?
So I work in the ER, and what do you do? You have a patient that comes in by EMS, and then after you've already started everything and done all this, then you find out they're a hospice patient, and then hospice calls you and says, "Is my patient there?"
So let me. I couldn't hear it entirely. You work in the ER?
Yes.
And you have a patient that comes in, you're starting to provide treatment, and then all of a sudden they do the, oh, by the way, I'm on a hospice, right?
Yeah, or the hospice nurse calls and says, "Did my patient come in? They called earlier and we're having trouble or whatever, but EMS picked up the patient and brought him in."
And you're all, wait, what?
Yeah,
right?
Because they're out in the CT machine, you know.
Right, of course, right in the midst of it.
Right. So, like, what is, just give me your thoughts.
What do you do?
Usually we will, like, hopefully if there's family there, we'll talk to them. Did I give you one? What's going on?
Can you all hear in the back?
No.
Can you hear?
We're gonna redo.
Okay.
Sorry. Is it too late to go to that one?
No, it's not too late. No, we're just in the midst. Do you have the microphone?
Sorry. Borrow this again. Sorry.
Okay.
Who was talking?
Hi, you have a question. What is it?
I got lost.
My question is, you are working in the ER, EMS brings in a patient, so you're treating them, and then you find out that they're on hospice. The hospice nurse calls and says, "Is my patient there?"
And you said right when the patient's in the
They're already
MRI,
in the CT. Yeah.
Yep. So what do you do? We actually, this was probably one of the most controversial questions that we had in Oregon, because we had one agency that said anytime a patient goes to the hospital, they just get discharged. And right? And others said, we'll keep them on until and unless there's something that's related to the terminal condition, and then everything in between.
You can ask the patient to revoke.
Yeah. It's because because we don't want to mess up what's going on. Sometimes we just do things and we didn't ask first. That does happen.
Yep. So if they are choosing, though, then they are, and thank you for the appropriate language, they are choosing to revoke if they want what would be considered that curative treatment. I know our agency has good communication with the local hospitals, and we have the conversation because patients already getting the scan in the midst of. So how do we deal with that? They don't want to admit the patient any more than we want the patient to be admitted. So we are able to communicate because we're a relatively small community.
So while David's reading, I should explain some of these cards are from a game we created based on the TV series What Would You Do? They're sort of ethical or challenging situations. Take it away, David.
Sounds like a terrific game, based on the questions we have. So ours is family request. Don't tell grandma that she's on hospice. Grandma does not have dementia. What would you do? I'm sure everybody in this room has faced this already. So I have to assume implicit in this question is that she did not sign the election of benefits. Because
maybe not.
Let's say she did, then she should already know she's on hospice. And my first question, if she doesn't, is how did that happen? Okay, so that's, and I've never encountered that, but that would be my first thing was like, hang on just a minute. How did we get her to sign if she doesn't
So
know?
how about this is the admit visit? The admission visit, grandma is grandma, right?
Sure.
Grandma's decisional. The team is walking in, or members of the team are walking in. Yeah. The kids stop the clinicians at the door and say, hey, by the way.
Sure.
Don't tell grandma.
Couple things. It's a great time to start asking about goals of care. just not using that phrase maybe, right? But little red flag, maybe they want hospice because they're looking for more caregiver hours or their medications are expensive, in the back of my mind. So I would have a goals of care conversation. And then we've several times been beyond that. We still think the patient qualifies, they really should be on hospice, everything else seems to check out. What our policy has been for quite some time is letting them know we work for an organization where identification is important, so we have to have our badges with us, and that includes bath aids and things like that. And they say hospice on the badges. So you need to know that that's part of what's happening. And I find like I push that a little bit because I don't make it a negotiable. Like we can take our badge off if that's going to upset. Like that comes with the territory. So that forces them to already understand that we're going to do what we can to respect things, but at the end of the day, you're on hospice. And then I also, because we have this with children, right, where people say, don't tell them that they're dying. I don't want to, but children aren't stupid. And so I often also tell folks, when there's this information that's important that's being kept from somebody who's involved, first of all, it's a disrespectful thing sometimes, or at least it may be more positive. It's more respectful to make sure that they're involved in these decisions. But also, the longer you go trying to keep important information from them, the more likely you lose the ability to control that. They're going to find out anyway. They're going to find out in a way that's not controlled or pleasant. And then you've got two problems, which is now they know what you didn't want them to know in the first place, and you kept it from them. So
that's perfect.
I don't know that we go that way, but those are the things we try to cover.
Thank you very much. Who wants to go next?
This is also, hospice is...
Don't everybody jump at once.
Back in the corner, hospice is also an elected benefit.
You want to
And we are required to elect it. And I've said before to families, if you were in grandma's bed, would you want to know?
I did get a card, but I'm not going off the card.
She's going off script.
Right on.
So I've had several instances. I order hospice. I'm not a hospice nurse, but I'm an ARNP that does home visits for patients that can't get out of their home or have difficulty getting out of their home. Most of these patients have dementia. Some of these...
That wasn't the example he had.
No.
That was a decisional patient. Okay.
Some of these patients have quite significant dementia and they have power of attorneys. And when we do talk about hospice, they may qualify, but the power of attorney disagrees that the patient has the capability of saying what they want. So for instance, I have a patient who has dementia. She does not want to go to the hospital anymore. And she's able to nod yes and no, but she's lost the ability to really formulate sentences. But the power of attorney says, no, she's not ready for hospice. And really what it is the power of attorney is not ready for hospice.
Right.
Exactly, yeah. Did you want to do your question?
Well, we can. It comes up a lot.
There you go.
Ours said, out-of-town family arrives and says, we want CPR done and we want to call 911. What would you do? I mean, obviously you have to have a conversation about who the power of attorney is, and it's not like a simple, quick conversation usually. When
The patient could still be decisional.
yeah, and if the patient is decisional, then yeah, it's up to them. So yeah, family dynamic.
Anybody else?
Decisional is such an interesting element just on its own too. And remember, it can come and go.
You know you want to go.
The question that we had was the patient needs a Plerex catheter. They asked you about getting this placed before coming onto hospice or wait until later. What would you do? I think first would be more about, that goals of care conversation.
Do you use a Plerex catheter on service? Do you have it placed once they're on service? Some of you do, some of you try not to.
Yeah, typically we have ours, we request that they have theirs placed before. And then that way it makes it easier for the nurse to go ahead and drain as needed.
Yeah, those of you who will have it placed after, are you part of a system?
Yes.
Yeah, which financially can make a difference, a substantial difference. We are not, and wow, is that expensive? You only do that once before you make other arrangements. $10,000. 10, 11, $10,000.
We just have a frank conversation with the family and or patient at the patient's decision hall and talk about the cost. And we just had one a couple of weeks ago that they were happy to have it placed before we admitted to hospice. So, okay, thank you.
That's good.
All right, how about
Thank you.
the Pat Justice table?
I don't know what you do about this. This is a little bit out of our
Yay.
league, but so the patient tells you she wants to continue to smoke while on oxygen, and the family says they will watch her. What would you do? My first response is get a whole crate of fire extinguishers and bring them over, but I know that's not the correct answer. So there's obviously some teaching there, but it's an ethical dilemma as far as I can tell, and I'd be interested how people handle that.
Yeah, how do you handle that? Excellent.
Back here, excellent.
You never got a chance before to do yours either, have you?
We had somebody who started vaping instead.
Vaping instead?
I mean, it's not necessarily better for you, but it won't catch on fire.
Yeah. Yes.
So we have a whole policy around this that can include ethics consultation. And unfortunately, it did stem from a death, somebody who actually died from burns, and there have been other burns. But our policy starts with risk mitigation, education and risk mitigation, and it might include supplying help with stopping smoking. It might include smoke alarms, that kind of thing. And it does include how medically necessary the oxygen is. So some of our patients, they're on oxygen, it's not really medically necessary. And so if it is determined to be medically necessary, either for palliation significantly or for life-sustaining, then, and the person isn't willing to quit or is still having near misses, we have a policy for watching for near misses like burns in the carpet and so on, and all of those have to be brought to the team. We also assess the risk to others. Are there vulnerable pets, children, or adults in the home? Do they live in an apartment building? And if there isn't risk to others, we have yet to actually take somebody's oxygen away that is still cognitively intact. Unfortunately, most of the people who are smoking in oxygen and having near misses are somewhat cognitively not intact, right, whether it's related to their meds or their illness. So our policy requires it to go to the ethics committee prior to removing oxygen from the home in a patient in which oxygen is medically necessary. So it's a series of steps.
Do you also use the OxySafe?
Yes. Any patient who anyone smokes in the home gets an OxySafe.
This gentleman has
Thank
a
you.
comment. Thank you. Oh, okay, gotcha.
What's an OxySafe? It's I don't know what the most recent version is. It used to be that there was one near the mouth, a sort of a clippy thing that if you go boom, it's not so boom. And then there used to be a second closer to the tank. We've used it. It has actually saved lives.
If there's fires, they melt, so they close up the oxygen in the tubing as well.
Say again?
The oxy valve or safe, it melts.
Oh, and that's how it benefits.
So then oxygen doesn't get through the tube.
Oh, thank you. So it melts if there's a
small nuclear
boom.
Reaction in the. No.
It melts and then stops the oxygen.
This past year, kind of related to this past year for the first time, I can't remember if it was our DOH or our JACO survey, but the issue was raised about us assessing oxygen safety in relation to the neighbors' homes.
Interesting.
Yeah, it was like,
wow.
Are you assessing for that level of safety? And that, it wasn't something that we had been doing before.
I had not heard that. Have others heard that before as well? Neighbor safety? That's amazing.
Maybe it's just an urban problem, but
Hey, that's okay. Thank you. We can put it on our radar. How about we do 2 more? I want to make sure you get out just a smidge early.
Oh. Okay.
You're having fun back there?
Oh, the family tells you we want Grandpa, who's already on hospice, by the way, to get an MRI because we want to know what the tumor is doing. What would you do? The biggest thing is we would educate on the disease process, our goals for comfort care, and kind of explain to the family that it's expected. So what is that going to change in how we're treating your grandpa? Second of all, it does say the family tells you, so ensuring that the patient, if that's aligning with the patient as well, because sometimes that's not always the case and the patient doesn't actually want to go get that MRI. If the patient does, aside from all the education, then typically they revocate off and seek that MRI. So,
Thank you. Any other thoughts on that?
Gina.
I'll just say this. On occasion, we've said, what would that change for you? And let them talk about that. And we also say, well, it's great that you're doing well. There may come a time that we do need some imaging just to keep you on service, just to continue to justify our involvement. And if and when we get to that point, we can talk about some imaging.
That's a good answer, too.
Okay, one more. Who wants to go? Were you pointing at the table of your posse up front?
Yes.
And nobody's tripping me along the way that they want to go. So here you go.
Okay, Maiska.
The family asks your staff, how come Grandma can't have a better wheelchair, e.g. a fancy electric one? What would you do? Probably just some education that basic DME is included or reimbursed through the hospice Medicare benefit, and we provide the same basic DME to all of our patients and kind of go through what we cover. And if they do want to pursue maybe a fancier wheelchair, that's something that we don't provide, that, and maybe give them the resources of where they can find something like that through Knights of Columbus or maybe another company like that.
We've had this conversation quite a bit. Thank you. So as we wrap up, the point of all of this is make sure you're consistent and that you within your agency, you know what it is that you're doing and how you're training your staff to train your community. So that they can live their best lives, because that's our goal, right? In the end, is not just a good death, but to live a best life through the last breath.
Thank you for staying for the last session.
And will you thank Barb for all the work she has done?
Well, and Meg.
Making this happen. Where's Meg? There's Meg right there.
Meg and Clint. Yes. What a crew. Safe travels, everybody. Thanks for coming to the conference. We'll see you next year back here in Chelan. And I'll take my cards back.